ophthalmologists, they always think, no, that's the eye. I don't know anything about the eye. And so they kind of shut down. And then when I talk to an ophthalmologist, they say, oh, no, that's the brain. I know nothing about the brain. I don't want to think about that. I just want to do surgery. I'm done. But truly, as a neuro-ophthalmologist, if you understand principles, as we talked about yesterday, the ABCs, those are some of the skills that you can use to apply, just as in any neurology subspecialties. So I think you're just as capable as anybody else. So don't be afraid, and please reach out and to ask me questions. I'm very open. Whenever you have a hesitation, even if I'm able to explain it in Vietnamese, my broken Vietnamese, I'm happy to do it also. Okay, so reach out to me. Ask questions if you don't understand. Okay, all right. So I'm going to start off first with a review of what we talked about. And today, what we're going to focus on is one question: is it the optic nerve or is it the brain? And the skills I gave you yesterday is going to help us answer that question for every one of our cases today. Okay, so think: is the optic nerve or is it the brain? And how do we figure that out? Okay. So first off, learning the basics of neuro-ophthalmology is important. Recall that we looked at visual acuities, right? And the visual acuities tells us if there's vision that's being affected in one eye, the other eye, both eyes, and whether that vision is in the eye itself, that's the problem, or is it in the optic nerve, or is it in the brain? So that allows us to answer that question. So remember the visual acuity. The color vision. When you have changes in color vision, typically it originates in the optic nerve. In many cases, if it's congenital, you can find it in the retina also. But certainly if you have one abnormal in one side and not the other, that is consistent with optic nerve problem. So remember that. But you recall also that it can occur in the brain, because if you have a stroke in a certain area of the brain, you can cause dyschromatopsia, or loss of color vision, where someone is born with color vision, all of a sudden they have a loss of color vision, and in both eyes, think about the brain. So that's the other skill you have. Pupil testing. When you're checking for pupils, it allows you to look whether there's an abnormality in the pupil or the eye itself. If it's affecting your vision, it's in the optic nerve, or is it further back in the brain? And how do we know that? Well, there's different ways to look for that direct versus looking at the consensual response versus the swinging flashlight where you're looking at the relative afferent pupillary defect. That helps you to localize whether it's on the right or the left. And then we talked about that pathway, and this is how you can determine if it's in the right or the left. Learning the pathway to the pupils. I spoke to one of your colleagues this morning. I said, well, I understand sometimes when you look at something that I'm showing you, you don't understand the underlying and the mechanism involved. I agree, there's some complexity to that. But just as in Vietnamese, when I was young, I was taught this phrase, "Được học lễ, hầu học văn," right? So what you want to do is just get the steps and the basics in first. Eventually, as you learn this, you'll start to understand the underlying nuances, the little special things that you kind of have to know to understand this better. But this is a beginning, your foundation. So understanding that pupillary pathway is important. And knowing that light-near dissociation can help you, because there are 5 things that can cause light-near dissociation, right? If you lose vision in both eyes, you can cause light-near dissociation. If you have a tumor or something pressing on the tectum in the midbrain, you can have light-near dissociation. If something happens in the pupil itself, in the ciliary ganglion, you can have light-near dissociation. So this is why testing the pupils that way is going to help you localize. So skills: first, visual acuity, color vision, pupils. Those are the things you want to think about when you see a patient that may have a neuro-ophthalmic problem. And then finally, we talked about confrontation fields. And in confrontation fields, it's an easy, quick, at the bedside, one eye at a time, covering one eye, checking all the 4 quadrants. And that allows you to, remember, localize. And that localization, remember all the different places that can occur, where if it's in the bitemporal area, that means it's in the chiasm. If it's homonymous, that means it's past the chiasm. If it's on one eye only, on one side only, likely it's the optic nerve. So keeping that in mind, those are the skills that you need for neuro-ophthalmology. All right. So I'm going to move on to one quick concept, and that is what I want you to know about the optic nerve. I know you're not an ophthalmologist. I don't expect you to know the anatomy of the optic nerve, but there are some pertinent, kind of very specific things that I want you to pay attention to. And this can help you as we review these cases today. So, as we talked about, all the things that you need to know in terms of looking at someone with neuro-ophthalmic problems, but in our brain, we use about 30 to 50% of our brain to control vision. That's a huge part of our brain. So when we evaluate the neuro-ophthalmic system, you're actually looking at 50% of the brain already. Consider that. And the testing you do, visual acuity, color vision, pupils, and confrontation fields, that gives you that information. So keep that in mind. And the visual pathway, it's not sharing. So the afferent visual pathway, as we talked about yesterday, Dr. I'm sorry, I keep Uma. He talks about the efferent pathway. So I'm talking about the afferent pathway. And the afferent pathway starts with when the light hits the eye, it goes to the retina. And the layer that you're going to be concerned about is called the ganglion cell layer. The ganglion cell layer, I tell my patients, it's a layer in the top part of the retina. And whoever looked at this first said, these are ganglion cells. But maybe if we looked at it first, we'd say those are apples, right? And so maybe they're apples. And in that layer, you have 1 to 1.2 million apples. Okay, imagine that. And when it's organized so that the apples are more concentrated in the middle. That mouse is not working. So the apples are concentrated in the middle here. And it's piled up here and then less out here. So imagine your apple. Each apple has a stem that comes out, right? To attach to the tree. So that stem will join and go in, right? So each apple, 1.2 million of them, bundle together at the stem to form the optic nerve. So your optic nerve is actually a bundle of stems that sends the signal from the eye, crosses over halfway, go this way, and synapse in the lateral geniculate. So that's it. That's what you need to know in the neuro-ophthalmic system in terms of the nerve itself. Okay, so think about 1.2 million ganglion cells or apples bundled together, send its signal out. When we look inside the eye, that area of the nerve that we look at right here, this is actually about 1.5 millimeter in diameter. And the thickness that we're able to see, that edge is about 1 millimeter in thickness. And that comprises the entire 1.2 million cells that's in there. So you can imagine how small and how intricate that is. So it's important to know, though, because there are certain features about that nerve that will help us determine there's something wrong with the nerve or not. So you don't look at nerves every day. You don't know what normal looks like. So how do you know what abnormal looks like? So I'm going to tell you what normal can look like and what abnormal can look like. So here, these are some examples of abnormal nerves. That one up there is a swollen optic nerve. That one there has a little bit of swelling as well. This one here has some abnormalities inside the nerve itself. There's some calcium deposits that can occur in the nerve. Just like any structure in our brain, in our body, we have variations that occur, and the optic nerve is no different. It can occur that way too. And these calcium deposits can cause problems in the optic nerve. So when you affect the optic nerve, again, it causes changes in vision, changes in color vision, changes in pupil reaction, and visual field defects. All right, so I think I've hammered these principles enough. You got it now. All right, so what's a normal nerve? This is a normal nerve. A normal nerve is one that's flat, okay? And it's round. And the vessels come out in the center. So you can see all these vessels here. And you can agree with me that it's nice and round, it's flat, vessels coming out. The color, we describe it as kind of orange, golden, pink. So we're looking to make sure the blood supply is normal, there's no discoloration, there's no swelling. And you can agree with me that when you look at that, that looks nice and flat. It's easy to focus on. So that's a normal nerve. So what's an abnormal nerve? This is an example of an abnormal nerve. Why is this abnormal? So if you look at the normal side, the other side, it has a brighter color, yeah? And it's nice and circular. It's flat. The vessels look okay, but that color is really bright compared to the other side. Why is that? Well, the reason is because, remember, 1.2 million cells bundled together. When you lose those cells, what happens? You now have less density in the cells. And so you can see behind that better, right? Just like anything that's not covered in detail. And so as a result, the back of that area is sclera, which is white. And so now you have white that's coming back at you. So when I see that the nerve looks bright like that, I'll say something has injured it. I no longer have 1.2 million cells in there, maybe 900,000, maybe 100,000, because I can see the brightness behind it so well. Okay, so that's why the color looks that way. Comparing between the three of those, you saw what we call pallor, which means that nerves have died. In the middle, that means the nerve is now no longer flat, right? You can see that there looks like with the cues that you can see with two-dimensional view, there's some elevation to the edges. You can't really see the edges very well, where the nerve ends, where the retina begins, and the vessels are kind of congested in the middle. That's a swollen optic nerve. And there are many mechanisms that cause swelling of the optic nerve, including ischemia, compression, tumors, infiltrations, many other things. So those are examples of what abnormal nerves look like. All right, so that is the start of priming. And then what we're gonna do is we're gonna switch here. And when I come back, we'll talk about the cases for afferent visual dysfunction.
Thanks so much. Okay, so thanks again for being here. I realize that Dr. Sanjeev is speaking on the other side, so a lot of competition, but you have chosen us. Okay, so we will do some summary. So yesterday we ate a few snacks. We talked about how we can analyze eye movements using simple diagrams. Then using that, we explained peripheral nystagmus. Okay, so let's see whether we can revise that. Okay, so this is basically what we saw yesterday. So if you want to look to the left, you have lateral rectus muscle and the medial rectus muscle. The lateral rectus muscle is connected to the sixth nucleus. The medial rectus is connected to the third nucleus. And these two are different parts of the brain, so they need a connection. The connection is medial longitudinal fasciculus. Then we said that volitional control comes from contralateral frontal eye fields. And then we said that for us to automatically, this is of course voluntary movement. I want to move to the left. I want to move to the right. So this particular part of the brain will make the eye look to the other side. So you remember in seizures from the cortical localization, the eyes often look away. In a lesion like MCA stroke, this side is not working, this side is working, so eyes look towards the stroke, right? So that's one application for it. Now, we also said that that's voluntary movement. Voluntary movement. Now, what about involuntary fixation? So while I'm talking to you, I don't need to think about look at you, look at you, look at you. I just automatically am looking at you because of the vestibular system. And we said yesterday the vestibular system is based on the head moving like this. So just to remind, if my head is moving to the left, this side gets more fluid because if I can follow this, there's fluid moving here, there's fluid moving here. But this is moving away from the wall, this is moving towards the wall. So just like waves, when it goes towards the wall, there's more waves coming in. Well, when fluid moves away from the ocean, when water moves away from the ocean, there are no waves. Right? So the same way, this one is moving towards, this one is moving away. So more signal on this end. This signal is sent to the which side? Right lateral rectus. Left, right, ventricular nucleus. Right, 6 nucleus. Okay? So this is how the vestibular-ocular connection is made. So if I move my head to the other side, this side gets more signal. Signal is sent to the opposite 6 nucleus. Left eye abducts, right eye adducts. That is the vestibular-ocular reflex. So we said that a person cannot look to the left because it could be a supranuclear lesion or a nuclear lesion. So a supranuclear horizontal gaze palsy or nuclear horizontal gaze palsy. To differentiate between the two, supranuclear horizontal gaze palsy cannot look to the left and paralyzed on this side. Horizontal nuclear gaze palsy cannot look to the left but weak on this side. Secondly, supranuclear horizontal gaze palsy cannot look to the left but upper motor neuron facial weakness. But nuclear horizontal gaze palsy, lower motor neuron facial weakness. And finally, we also said that the vestibular system is connected to the 6 nucleus. So, and that is the local reflex. So, if it's a supranuclear horizontal gaze palsy, the vestibular-ocular reflex will be intact. While in the nuclear gaze palsy, the vestibular-ocular reflex will be gone. That's how we revise. Correct? Okay. And then, okay, so any questions at this stage? Even in Vietnamese, we can ask in Vietnamese. Because today we have a lot of time. We have until 12. So we should make it like any part they want me to explain. Okay. If there are no questions, then everybody is clear. Because the reason why I want to stop is because every layer is getting more complicated. So we want to understand this layer, then we add a second layer. So we must understand this first, then we will add the next layer. So yesterday we said, if we damage the 8th nerve, what happens? Okay, we said, if I turn my head to the left, this one fires more, signal sent to the right 6 nucleus, right eye attacks, left eye attacks. And I turn my head to this side, this one fires more, signal goes to the opposite 6 nucleus. This guy attacks, this guy attacks. When I'm standing straight, both of them are same. And then, if I damage one side, now this guy is firing. So it looks like my head is turning to the left. So my eyes will move towards the right. Like as if my head is turning to the left. Because now, only one side is working. So it looks like I'm turning to the left. So my eyes will move as if my head is turning to the left. And then I will realize that I'm not looking in the right direction, I can use voluntary pause to bring it back. Then, because the imbalance is still there, it drifts. And then I bring it back. Drift. And then I bring it back. So slow pace, fast pace. Slow pace, fast pace. Slow pace, fast pace. So that is peripheral nystagmus. And the key thing about peripheral nystagmus is it does not change direction because it's got to do with imbalance of one ear. So whether I look up, look down, look straight, look to the left, look to the right, it's always beating away from the side of the TV. It's mixed horizontal rotatory. Remember we said it's mixed horizontal rotatory because the semicircular canal are positioned in such a way that these two cannot cancel each other out, while this is very prominent. So it's mostly horizontal with a component, because if this side is dead, this side is dead, these three are functioning, three semicircular canal. This one is working, this one is working, this one is working. These two, to some extent, one is like this, one is like this. So they can, because they're going slightly in the opposite direction, they cancel each other out. The one that is completely not cancelled is horizontal. So the vector of the nystagmus will be mainly horizontal, but because this and this are still intact, okay, if this was like this and like this, there would be zero, because this goes up, this goes down, each one cancel each other out, plus, minus, gone. But because it's tilted like this, it cannot cancel each other out. So therefore, therefore the nystagmus is mainly horizontal, but a little bit of torsion. Okay? And then finally, the nystagmus is present at rest. It's present at rest, but most prominent when you take away visual fixation. Right? So maybe just to revise, I'll just show you again. So this is a case of peripheral nystagmus, present even at primary position. When he looks to the left, it beats in the same direction. He looks the opposite direction, it still beats in the same direction. It doesn't change direction. But it becomes much more prominent when you remove visual fixation. When you remove visual fixation, it becomes much more prominent. Okay? So, essentially, this is it, right? So, to summarize again, because some of you are new. So, we were saying that if one side is damaged, these three are functioning. It looks like your head is turning to the left. If these three are working, what will be the direction of the segment? Well, this is unopposed. This and this are almost opposite each other. So they will cancel each other out, more or less. And only some of it will be remnant. So mostly horizontal with a hint of torsional. Mostly horizontal with a hint of torsional. Okay? So these are the key things we discussed yesterday. Okay, and then let's see now. Yes.
Thank you very much. I would like to ask, you mentioned before that when you remove the eyesight, the nystagmus is going to be worse, and I understand based on your explanation before, just pattern recognition. But when you remove the eye, then you lose a sight. Then where do you get the drive to correct the position of the eye with a fast beating if you're not looking at anything?
Okay. So very good question. So basically, what is happening is if the nystagmus is so active, patient is going to feel very distressed. So you will feel like you want to vomit, you will feel very unsteady. So So the cerebellum uses visual cue to automatically give an opposite stimulus to suppress the result. Okay, because it's making the patient very uncomfortable. The cerebellum would say, no, my master is not comfortable. Let's help him by using the visual cue to suppress it. Now, the eye can only use visual cue because the eyes have no proprioception. If we have proprioception, my hand is here, I know where my hand is. But when you close your eyes and move your eyes, you can feel your cornea, but you don't know where your eyes are. So the brain only uses vision outside to know where your eye is. Okay? So when you remove vision now, the cerebellum is confused. How much must I do to suppress it? So the cerebellum decides. And so the nystagmus is worse. Okay, so it is the underlying nystagmus. And now the cerebellar influence is lost. Just like I have a problem in the posterior column. I'm very unsteady, but I'm using my eyes so I can balance. The moment I stand and close the eyes, I'm going to fall because the cerebellum was relying on eyes to balance myself. This is peripheral pathology. If the problem is in the cerebellum, whether my eyes are open or closed, I'm going to be unsteady because the cerebellum itself. So that is Romberg sign of the limb. Now the Romberg sign of the eye is the same principle. Peripheral nystagmus due to imbalance of the semicircular canal can be suppressed by the cerebellum. So that's why this man's nystagmus is so difficult to see. It's so difficult to see. So once he closes his eyes, his underlying nystagmus appears because the cerebellum cannot suppress it. So I think now I understand why you're confused. Because you're saying, where is the nystagmus? The nystagmus is the problem. The cerebellum is dampening it and making it look like there's nothing going on. So we want to remove the cerebellar influence by closing the eyes. Remove the cerebellar influence by closing the eyes. The cerebellum cannot work before. Here, close the eyes, cerebellum cannot work. The underlying severity of the nystagmus comes up. So like I said yesterday, this patient, it's difficult to appreciate it. But if you put on very thick magnifying glasses, if you go to your ENT clinic, they buy commercial glasses called Frenzel glasses, which cost about $5,000 US. Okay, so this is my version of it. So I just make very thick glasses. Okay, and yesterday I showed you, right? So these thick glasses, if you put it in front of the patient cannot see outside. I didn't show it to you, but if the glasses are so thick that the patient can't see now. He just sees very, very blur images. He just sees light, that's all. Okay, so I have removed visual fixation by putting the glasses. So you see, with this is his realness now. Now with the visual normal, the nystagmus is suppressed. When the vision is normal, the nystagmus is suppressed. When the vision is reduced, in other words, close the eyes, the underlying nystagmus comes up. Right? So likewise, this patient also, his nystagmus is peripheral because it's purely horizontal, mostly horizontal with rotatory and always in the same direction. But again, very difficult to see because the cerebellum is suppressing it. But once I put on the glasses, it appears. Right? So the appearance of the nystagmus tells us this cannot be central. This must be a peripheral nystagmus. So likewise, this man, well, we were lucky. His eyelids are very thin. You can see his eyeballs through his lids. So his nystagmus is definitely peripheral because unidirectional, mixed horizontal rotatory. Okay, now let's compare and contrast this with this patient. What is the difference in this nystagmus? Firstly, primary position, nothing. When she looks to the right, it's beating to the right. When she looks to the left, it beats to the left. So, very different. In English, there's a phrase, chalk and cheese looks the same at first, but we know chalk and cheese are very different. Right? So, nystagmus to untrained person looks the same. But we know now, the peripheral nystagmus is present at primary position, mixed solid ocular rotatory, away from the side of the ear, and always between the same direction. This one is the opposite. Not present in the primary position. Only when she looks to the left, she's beating to the left. She looks to the other side, beating to the right side now. First beating to the left, now beating right. When she looks up, beats up. Looks down, beats down. This is very different from Melanie. Secondly, their torsional component knows purely horizontal. And lastly, I didn't show you here. If you put on the glasses or take off the glasses, like patients with cerebellar disease, when they walk to you, they walk like this, and whether you close the eyes, open the eyes, they are already unstable, no difference. Right? So how do we explain nystagmus? How do we explain this nystagmus? How do you explain this nystagmus? Okay? So we have to go back to this diagram again. So first, 6 nucleus and third nucleus, right? Okay. Now, this part gets a bit difficult. So I want you to pay attention. Okay? And I sense that some of you are new. So before I go into this new, I just want to make sure that yesterday's lessons were on. Just so if you bear with me, just get the sense. Just go through very quickly all the cases that we had yesterday so that everybody's on the same page. Okay? So, this man, when he looks to the right, no problem. When he looks to the left, the right eye does not adduct. So we draw a diagram like this. We connect it up. And we say how to make the arrow red. How to make the arrow red. Okay, so it can be a muscle restriction, can be neuromuscular junction problem, or it could be an isolated third, or it could be an internuclear ophthalmoplegia. Okay, so because he's got this nystagmus, vertical as well as abducting nystagmus, the nystagmus here is not peripheral, correct? Because it's beating up. Peripheral nystagmus is horizontal rotatory. This one is vertical. Can you see? It's beating up. So, which of these diseases causes central nystagmus? This is peripheral nervous system. This is peripheral nervous system. This is peripheral nervous system. Central nervous system. So, we made a diagnosis of internuclear ophthalmoplegia. Okay? And then we also said, we introduced this idea that his head is tilted to the left, eyes are up, one eye is down, and we call this skew deviation. Skew deviation is also a sign of central nervous system disease. And if later on we have time, I will explain to you why skew deviation occurs. Okay, so this is the brain scan, shows a lesion in the right medial longitudinal fasciculus. Okay, then we practiced yesterday how to figure out this lady's complex movement problem by breaking it up into steps, just like mathematics. If I give you a formula, if I give you a 245 and 456, many of us will use the calculator. But in the old days, we will write down the steps and go step by step. So what is the first step? Figure out what's wrong with the first eye. Sorry, the first picture. So she's looking to the right, 2 arrows are red. Right? The 2 arrows are red means it must be a lesion in the 6th nucleus. Okay, then we go back to the second picture. The right eye is not adeductic, so it could be a lesion in the medial longitudinal fasciculus. Then you put the 2 pictures together, then you realize, oh my God, it's in the same part of the brain. It is the same side of the brain. Left, right-sided pons. So a lesion in the longitudinal fasciculus and the 6th nucleus will cause a complex eye movement problem, that is this problem. Okay, it's called the 1.5 syndrome. Okay, but more importantly, I'm teaching you how to figure it out. So we did this yesterday. For those of you who are not here, a quick revision. The rest of you who are here, bear with me so that it's a good revision also. Okay, so that's when we introduced the peripheral necessity. Sorry, no, actually we talked about volitional control, right? We said if somebody wants to look to the left, this is the movement. This lady couldn't look to the left.
Look to the right. Now look as far as you can to the left.
So very simply, if you draw the egg diagram,
Right.
the egg diagram must look like this, right? Because 2 arrows become red. And 2 arrows become red, the only lesion could be 6th nucleus. Very nice. Happy answer. Okay. But we also said that it can be a lesion in the right frontal eye fields. Right? Frontal eye fields. And left 6th nucleus will cause the same eye movement problem. Right frontal eye fields and left 6th nucleus will cause the same eye movement problem. So how do we differentiate that? We already said just now. Okay. Right frontal eye fields will cause left-sided weakness. Left 6th nucleus will cause right-sided weakness. Right frontal eye fields will cause upper motor neuron facial weakness here. Left horizontal gaze palsy will cause lower motor neuron facial palsy. And then we introduce one more idea, which is introducing the 8th nucleus connection to the contralateral 6th nucleus. So if this lesion is here, it's going to affect the...
Look to the right. Now look as far as you can to the left. Right at the camera, please.
So when I do the vestibulo-ocular reflex...
So with the VOR, there's no real change.
So what does that mean?
Okay.
The lesion must be... So we have three ways of sorting it out. 3 ways of sorting it out. Okay? Side of weakness, type of facial weakness, and Doll's response. Okay? Okay, so then we went to understand this, which we by saying what happens if we do this. Okay, we said that because of the imbalance, normally both sides firing, one side not firing, it looks like my head is turning to the left, so my eyes drift to the right, and then nystagmus comes on. So that's what we did. Okay, and then we introduce this patient. Okay. Okay. Any points, questions at this stage? Then we'll go to, if not, we'll go quickly to this to understand why she has this problem. Okay, to understand this, I need to introduce a few more pre-nuclear influences. So yesterday we talked about supranuclear influence from the frontal eye fields. We talked about some reflex pre-nuclear influence from the vestibular system. But I need to introduce 2 more people. Okay, they are known as burst neurons and neural integrators. But again, the words confuse us just like just now. You can just call them apples or oranges. So what I've done is change the name. Okay, there are 2 sets of neurons you must know about. go there, and stay there. Okay? Now, why is that important? Because when you start the car this morning, what do? You put your car on first gear. When the car starts moving, second gear. Faster, third gear. Very fast, fourth gear. Now, why do you need the first gear? Because you're starting from zero velocity and you need to push a heavy car. Now, your eyeballs, there's weight. Okay? Weight. Heavy. The extraocular muscles are very thin muscles. I have to carry this eyeball and move. How fast? Look at my cut. How fast is that? Super fast, right? Look at my cut. From my right frontal, I should say, look to Dr. C. Dr. C. Look at Dr. C. See how fast it was? Can you imagine trying to do that on a mechanical machine? Amazing, right? So you can't do that unless you have a first gear. Because you have to start from zero velocity. So what's the first gear? Go there. Right? So the go there will make the eyeball move from zero velocity to maximum velocity. But if you travel your car on maximum velocity, you won't do that, right? You will slowly, second gear, third gear, fourth gear. So the eyeball needs to slowly, second gear, third gear, fourth gear, and stay there. To stay there, okay, for those of you going for exam, it's called neural integrators. Neural integrators, because if you remember, many of you do mathematics very well, so I'll show you. It's called neural integrators because, you see this formula here? Right? It's an integration, right? Now, so what does the brain do? It integrates position of the eyeball to the velocity. Brilliant, right? Because far away, go fast. Coming close to the position, slow down. So straight away the brain knows what to do. If I'm far away, I'm using lots of speed. Once I approach, slow down. So that kind of firing, which is like this, is not the same as this. The Goda neuron is just brr, brr, just to make the eyeball start moving. But after that, the second neuron has come in and says, go there, stay there. Why stay there? Because you need to reach the position. Now remember, your eyeball cannot overshoot and hit your orbit. You cannot have a sound like a car. It must go nicely and stop. Right? So to do that, you need the second set of neurons. The go there neurons must be supported by the stay there neurons. So where are the go there neurons? So your frontal eye field says look to the left. It doesn't go straight to 6 nuclei. It stops in this group of neurons called go there neurons. The go there neurons will take the signal, change it to it's like the first gear. This is the first gear. Okay, it's called PPRF in your textbook, parapontine reticular formation. But as clinicians, we don't need to remember the name, but we need to remember the function. Go there neurons. Okay, go there neurons. Okay, so now the go there neurons are firing and telling the 6 nucleus, go there. But once the target reaches, the stay there neuron must come. Where is the stay there neuron? Most of them are in the cerebellum. Most of them are in the cerebellum. So cerebellum plays an important function to keep the eye there. Okay? Now, not to worry. It will become very clear to you now. I am going to take 50 tablets of phenytoin now. 50 tablets. What will happen to me? I will get phenytoin toxicity in my cerebellum. Correct? So, because it's the commonest in the hospital setting, most times when we see somebody who's poisoned by something, it's usually our phenytoin, right? If I take 50 tablets of phenytoin, my cerebellum will not work. Okay? So, I will come to you, very unsteady, then you put me on a chair, then you ask me to move. You want me to move to the left. My frontal eye field is okay? Correct, because pericardium does nothing to my frontal eye, right? It sends a signal to my left pons where my Goda neurons are. Goda neurons are okay? Correct? No problem, because pericardium doesn't affect the Goda neuron. So eye off goes there, which is Dr. say. Okay? But the cerebellum is not working to do the stay there function. So what happens to eye off? Transfer to the center, because this one no need anything, right? Dead body, the eyes are straight. Right? Then I said, oh my God, I wanted to look at Dr. Say. I don't want to look at the machine. So what frontal eye field will say? Go there. Go there. And then the stay there not working. Right? Then again and again, I should say, no, I want to look at Dr. Say. Fast, slow. Fast, slow. Now I'm very exhausted looking at him. I don't want to look at him, I want to look at her. Okay? So my left frontal eye field working. My right, so left frontal eye field will send a signal to my right sixth nerve through another set of Goda neurons in the pons. They're all working. So can they reach the target? Yes, reach the target. But cerebellum not doing the job. So what happened? Okay, then again frontal eye field says go there, but stay there not working. Go there, stay there not working. Go there, stay there not working. So now nystagmus was beating towards Dr. Say. Now the nystagmus is beating towards the lady. Direction change, which is opposite of peripheral nystagmus. Opposite, complete opposite of peripheral nystagmus. Now I said look up. Okay, I look up, go there, neurons working, but stay there, neurons not working. So what happens? Up, up. So even when I look up, it's beating up. So gaze dependent nystagmus. So that's why the term came up. Gaze dependent nystagmus. Classic central nystagmus. Ominous central nystagmus. Completely of peripheral nystagmus. Okay? See carefully. The other name for this is gaze evoked nystagmus. Why? Because just now you saw our patient, the lady, when we put the glasses, primary position already beating. So she doesn't need to move her eye. Already the imbalance is there for peripheral. But for central, when I had looked straight at the camera, you wouldn't know I have got cerebellar pathology from peripheral. But when I looked at Dr. Say, okay, when I look at her, so gaze evoked nystagmus. So these two terms are nice terms to remember because they explain the pathophysiology. Gaze evoked or gaze dependent nystagmus. Okay, so now, so far I have not asked you to memorize anything. Only one thing I asked you to memorize. Frontal eye fields are crossed. Now I have asked you to remember second thing. What is that? For central nystagmus, the pathology is in the stay there neurons. Stay there neurons causes, pathology in stay there neurons will cause horizontal, gaze evoked nystagmus or gaze dependent nystagmus, like this. Okay, now I'm going to give you a quiz.
Right camera. Right at the camera.
Sorry. Okay, while I'm finding the slides, Any questions at this stage about gaze-evoked nystagmus versus peripheral nystagmus? Yes, please ask while I find my slides, because I'm not sure which menu I put it in. You can ask in Vietnamese also.
So you mean in case evoked nystagmus, and I want to know if the patient look at every direction, there's still nystagmus, right? Even in up, down, or right, left side. But why there's still there's no rotatory movement of nystagmus?
Very good question. So let's think about it. Okay. Now I'm going to hold that question in a while. I'll answer when I explain what it is. Once again, okay, just hold that thought. Very important question. I'll answer in a minute. Okay. Any other questions? While I find this, I'm not sure why I cannot find it. Okay, I found it. Okay, now I'm going to give you a clue. Okay, I'm going to give you a quiz. The winner will get a prize. You will make me very happy because it makes me understand. Now, this is how I damage my stay there neurons very easily. Radicline, alcohol, genetic disease, cancer, stroke. All this can cause very bad. But what if I can take an injection? I go to the pons, okay, and I inject into the PPRN and damage the go there neuron. What do you think is going to happen? No go there neuron. Remember, imagine your car has got no first gear. So what's going to happen when you start the car? Boom. You will stop. Then you start. Stop. Because there is no first gear. Right? You try that now. Try to start your car on third gear. And you will press the accelerator fast. It will move, but it will stop. Okay? So now, if I'm saying frontal eye field, look towards Dr. Say, frontal eye field is working. Goes the signal to the QPRS. QPRS is not working. Cannot go there. So what happens? The sound effect is fine. Finally, it reaches it. Because there's no go there neuron. So the eyeball has to be carried. You cannot, right? But the sixth nucleus is still working. You still can move. Still can no first gear to. Okay, so if you think that's theoretical, this lady was asked to do saccades. Normally we test saccade like this. We use an object, pen, finger, pen, finger, pen, finger, pen, finger. So how my saccade is? Disappear, 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 disappear. Right? For her, it's very, very slow. All the way to the right. See that? It's all the way to the left. All the way to the left. All the way to the left. See how slow it is? It's supposed to be, if I ask her to do like this, that's normal. But I didn't ask her to do pursuit. It was a cut. Look at my finger. Pen, finger, pen, finger, pen, finger, pen. That's normal person like me. But for her, this still can move because frontal eye field is working. This nucleus is working, but no go there neurons to have the first gear. So very slow, very slow. So, but if you look at this carefully, 6 nucleus is working. What else can be working? VOR should be normal. VOR should be normal. So if you look at her now, after showing her difficulty in eye movements, I will do a VOR, and her VOR will be super good, super normal, because VOR is outside the PPRN. You can see vestibular ocular reflex, it will not be affected. Remember just now, that lady had a 6 nucleus lesion. When you do the VOR, cannot overcome. But now, the lesion here, VOR should be normal, and you will see a VOR is quite normal. All the way to the right. All the way to the left. Move as fast as you can. All the way to the left. Okay, so now I'm going to do the VOR for her. All the way to the left. So now it's still saccades, So slow saccades. Okay, now I'm going to do the VOR. See the VOR? Normal. Full extent of movement. No issues at all. Okay? Now, this is an elder sister, older sister. Okay? And her eye movements are so bad that it's hardly moving. Okay? It keeps stalling. And because she is older, she's experienced this longer, she's learned that if somebody calls her to look at Dr. Say, instead of doing this, she will do this. What has happened? See my eyes? Looking at him now, right? Now if I want to look at the lady in green, instead of doing this, I will do this. Now I can still look. What did I do? I used the VOR. So you will see her swimming and a ponytail swimming because she uses a VOR, because she knows that the cards are so slow, she cannot wait for her eye to go like that. Much faster too. So you will see these patients doing that. So in the later part of the video, my nurse will be standing in front. I'll be standing here and say, look here. Instead of looking like this, she will do that. Okay? See, her movements are so slow. It's at the advanced stage of the disease. The first year was not working at all, so it becomes very, very severe. Okay, so now I'm going to call her to look to the right. See how she swings. Okay. Now this is the eldest daughter. This is the father, who's in a nursing home, and his eye movements are very severe. His ataxia is also very severe. He's got cerebellar ataxia, for not related to the lesion in the PPRL. He's also got cerebellar degeneration, and you realize his speech is very cerebellar speech, and his eye movements are also very severe, very similar to the daughter's, overcome by vestibular ocular reflex. So what do you think this is? Familial autosomal dominant cerebellar ataxia with poor horizontal saccades. If I phrase it again, I'm sure you'll get the answer. Familial autosomal dominant with slowing or horizontal saccades. This is spinocerebellar degeneration type 2. Like what Dr. Melanie was saying yesterday, clinical medicine gives you superpowers because you can look into the gene and predict. In this patient, we can predict its SEA2 because only in SEA2 this kind of slowing of saccades happens, because this old term for SEA2 was oligopontocerebellar degeneration. Why? Because the pons is atrophic. What's in the pons? PPRL. The PPRL is gone. That's why the pons is atrophic. So the patients have cerebellar degeneration, but in addition, their PPRL is not working, and that's why they have slowing of saccades. So when you see this, so in our Asian population, the two commonest SEAs are SEA3 and 2. Okay, I'll teach you how to recognize them without needing genetic test. 2, and 3 will be one. Okay. I don't believe the movement disorder doctors when they say, oh, it's not specific. But that's because they don't check the eyes properly. Okay, they want to do gene test first. But I always check the eyes properly, and if you test the eyes properly, you can predict the 2 commoners in our context. Commoners in the West is Friedreich's ataxia, but for us it is 2 and 3. Okay, so 2 already demonstrated. Okay, now we come to the gentleman's question. All along we've been talking about horizontal eye movement, correct? So, my God, what am I going to do for vertical eye? How am I going to do this? Okay, am I going to spend another 1 hour explaining this? You don't have to. You know why? Because what we have learned in horizontal eye movement is the same template. In English, the word template, the same pattern is used for vertical movement. Only thing we need to do, okay, this picture looks very complicated, right? So don't worry about it. Just remember this template. Okay, take this template, get into the elevator, press the elevator, go from the pons to the midbrain. Step number 1. Because most of your vertical movements are in the midbrain, from your 3rd nerve and 4th nerve. Superior oblique, okay, inferior oblique, superior rectus, inferior rectus, all lying in the midbrain. So your centers for vertical cannot be lying in the pons, must take the elevator and go to the midbrain. Number 1. Number 2, all the characters are the same. All the characters of the drama of the play are the same, except they have different names. Okay, frontal eye field, same. Frontal eye field says look to the left, look to the right. Now the frontal eye field says look up, look down. Okay, so that is the same. Number 1. Number 2, what else have we learned? The nucleus, right? The nucleus. Just now was 6 nucleus. Now it is the 3rd and 4th. Character number 2. Who's character number 3? Vestibulo-ocular response. So when I move my head left and right, I'm looking at the gentleman in black. I'm looking at him without saying, look at him, look at him, look at him. Because my reflex is working. But if I decide to do this, it's still working. Why? Because now this canal and this canal, now you know why the shape is like this. It's now horizontal, this one is active. Now vertical, when I move back, this one will be active. When I move forward, this one will be active. Right? So this signal is sent to the 3rd and 4th nucleus to do the opposite movement. That means when I move my head down, my eyes must go up. When I move my head up, my eyes will come down. So simple. But the only problem is, 8th nerve is in the pons. 3rd nerve and 4th nerve is in the midbrain. But there's only one elevator. Who's the elevator? MLS. Medial longitudinal plexus. The same elevator. So this influence must reach the 3rd and 4th nucleus through the MLF. Okay. So same thing. When I move I'm able to look at the gentleman at the back because my superior and semicercular canals are working and the signal is sent up. And that signal is then sent up through the MLF to the 3rd and 4th. So we have frontal eye field, we have nucleus, we have vestibulo-ocular reflex. Okay, what about Gaussian neuron? Okay, so Gaussian neurons is called PPRF in the horizontal movements. Now, this part for the exams you need to remember, but after you pass exams, you're only interested in one examiner, your patient. And the patient doesn't care whether it's called PPRF or some, I always joke, they sound like Harry Potter, Harry Potter got chance. Rostral, interstitial, medial, nocturnal, fasciculus. And then everything will gravitate, right? So RIMLF is the brother of PPRF. So remember, brother of PPRF is RIMLF. He will go there. When you want to look up, look down, he's the one who says, go there, go there, go there, go there. Okay? RIMLF. What about stay there? Well, the main stay there is imbalance. cerebellum is such a big structure, bilateral. It's got influence everywhere in the body. Superior peduncle, middle peduncle, lower peduncle. You know, cerebellum is like an octopus, right? It's holding on to your cerebellum, holding on to your midbrain, holding on to the medulla, controlling everything through all the tentacles. Right? So cerebellum will control everything. Okay? Now, there's only one difference that you need to remember. Two differences. Actually, it's very interesting. The books don't talk about it, but it's very interesting. Unlike horizontal movements, okay, left, right, here we have two eyes to coordinate. Right? One eye must move together with the other eye. If one eye goes faster than the other eye, you get confused. So to control, to make sure that this right and left is balanced, the brain decided to evolve a bridge that goes across, that connects the right side and the left side. Okay? That is called the posterior commission. Okay, one extra structure. Because of the complexity of looking up and down and controlling the right side and left side. Because when you look left and right, there's no need to control left and right separately, right? You move in. But now if you move up and down, this one cannot move on its own. This one cannot move on its own. Must coordinate. So to coordinate, we have evolved another structure called a posterior commission. Another set of wires to connect the two sides and to make sure you move together. Posterior commission. So that's one addition there in the notes. Okay? And then finally, this is the part that's very interesting, but I emphasize the book. When I move my eyes to the left, and I move my eyes to the right, what happens? If the energy is the same, your left wing, right wing, so we say that in America. Yeah, but nowadays everybody is so left wing and right wing. So whether you're left or right, the energy is the same. So when you look up and down, is the energy the same? Because of our friend gravity. Gravity is going to make looking down easier. Looking up, difficult. Looking up is going to be more difficult. Looking down is easier. So one way that the brain has decided to make things, to balance it out, is looking up, control is bilateral. Looking down is unilateral. Because you've got gravity to help. So why do you need too much help? But looking up, okay, two of you cooperate. Right side, left side. So RIMLF, when it fires for go there, it will work on both up gates, but only on one side down gate. Okay, the left RIMLF will work on both up gates, but only on the left down gate. So, because of the advantage of gravity. So that is the only two differences that you need to remember. Well, there are a few differences. First, you have to go to the midbrain. So I have to travel up the elevator. Then the name of the PPRF, both neurons, theta neurons are slightly different, but similar. There is a posterior commission to connect both sides. And there is a difference between up and down. Okay? So, this looks difficult, right? But I'm going to tell you that actually you've been seeing such cases all your life. Like this patient.
Straight ahead. Now look up.
This patient came to my clinic saying, I am falling all the time. I'm slowing down. My arms are not swinging. I'm falling all the time. But my eyesight is not so good. So we ended up in eye clinic. Right? So when we tested her, her visual acuity was normal, color was normal, visual fields were normal. So ophthalmologists didn't know what to do. So they sent to neurophthalmology, saying something else must be wrong. Because the general ophthalmologists often don't focus on eye movements, they focus on the eyesight alone. And her eye movements, the picture is much better in this patient. Okay, so this patient, so I'll show you this, then I'll show you the difficult one. So when this patient looks up and down, the instructions given is the same as earlier. Remember? To test horizontal circuit, bend, finger, bend, right? Now it's 10 finger, 10 finger, 10 finger. Look at my set. See how fast it is. 10 finger, 10 finger, 10 finger. Hook, 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 hook. Very fast, right? For him, it will be like up and down, very slow. Like as if I told him to do this, but I didn't. I did this. Okay? So watch. And the other thing that's very useful for most clinicians, you know, is that eyelids are very good friends with vertical. They are also holding hands, like holding hands like that. So when the eye moves down, the eyelid will follow. The eyelid control is also similar sort of brain control. We don't need to go into the detail. Okay? But they always follow. Makes sense, right? Because when the eye goes down, eyelid must go down. Right? The eye goes up, eyelid must go up. Because if the eye goes up and the eyelid is like this, you can see. So we have linked eyelid and vertical movements together. So in this patient, you will see eyelid is confused. Am I going down? No, you go down first. Maybe I don't come, I'll come later. You know, the kind of confusion comes in because it is lost by this problem. Okay? So that's the other clue.
Straight ahead. Now look up and look down. All the way down. Good. Look way
See
up.
nice?
And look way down.
See how slow it is?
As far down
Just like
as
the
far
lady
up
just
as you
now.
can. And now look
She
straight.
had horizontal flowing. Now it's
The
vertical flowing.
camera. Center of the camera. Blinking light. Finger. Camera. Finger.
See? So slow.
Camera. Down at the finger.
Finger, camera.
Way down. And look at the camera.
Because the first gear is not working.
And wait.
First gear is not working. Go there, neurons are not working. So just now, in the go there, neurons was in the PTRF. Now, it is the IMLF. And so, in this disease called progressive supranuclear palsy, PSP of Parkinsonism, where is the atrophy? Emperor penguin, right? You know the hummingbird sign, right? The pons is very fat, normal, but the midbrain is atrophic like this. So it looks like a hummingbird. Can you see this hummingbird? Fat, normal pons, and this one line. Why? Because what are the structures in the pons? In the midbrain. RIMLF, atrophic, slowing of vertical. Periapictal gray controls gait. Patients are falling. Subtension nigra. Where is subtension nigra? Midbrain. Right? Subtension nigra is in the midbrain, right? So, atrophic. So, Parkinsonism. So, this is the pathology in PSP. Okay. Just now we saw SCA2. The CA2, the pathology is where? Cerebellum and pons. Cerebellum and pons. So the pons is atrophic. Midbrain is normal. So in the old literature, oligopontocerebellar degenerative. The old book. But now we know it is genetic, so we use the proper term. Okay, again, PPRF is atrophic. So eyes not. So you are already seeing these patients, but now I'm explaining the underlying physiological and anatomical basis for that. Okay. Now, the second part of the video is very important also. Just like earlier on, the patient was using the VOR. This patient can use the VOR to overcome the deficit. The VOR should be normal.
Straight ahead. Now look up and look down. All the way down. Good. Look way up and look way down. As far down, as far up as you can. And now look straight. Look at finger with the camera. Center of the camera. Blinking light. Finger. Camera. Finger. Camera. Down with the finger. Way down. And look at the camera. And wait.
Okay. Then after that we do this. And his VOR is full. Vestibular ocular reflex full because like the horizontal patient, VOR is normal. Okay, now to prove to you that you all are experts in this already, I'm going to show you this patient who came to us with just acute onset of vertigo, dizziness. And yesterday, just to revise, what did he say? Vertigo, central operational features. Yes, he had unsteadiness of gait, weakness on one side. Okay, so it is central. First time ever in his life, lasting many hours. So diagnosis is stroke. But then we don't like to just make a diagnosis of stroke. We want to say where it is. So we looked at his eyes. I want you to look at his horizontal movements. I always use it to compare. Poke, 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 poke. Then I ask him to look up and down. Should be poke, 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 poke. So okay, tell me what you find in his saccadic speed. Perfect, right? Okay, now you compare with the horizontal. It's instead of tuk, 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 it's but now I want you to look carefully and say, it's up and down equally affected. Down is affected more than up. So now you know the anatomy. And so we told the radiologist, show us a lesion on the right side of the midbrain affecting the RIMLF. Because RIMLF controls both sides. So even one side affected, up is not too bad, but down here will be terrible. One-sided RIMLF. So I always tell my residents, you must tell the radiologist where the lesion is, not the other way around. Okay, so that's what we found. Okay, so it was a good test for your skills. You all understand now? Remember we said RIMLF has bilateral control. The Goda neuron for upgate is bilateral. While the Goda neuron for downgate, RIMLF, is unilateral. Why? Because downgate has got assistance from gravity. Right? So we naturally evolve better control for upgate because it's easier to go down. But when there is a lesion on one side of the RIMLF, this side, Goda is affected, but the other side is moving. So the other guy, just like picture with motor neuron picture, the other side RIMLF will try to make him go there. But the downgate only relies on the right side. So downgate is the worst. So unilateral downgate is the cut flowing, highly localizing for ipsilateral RIMLF. So your physician can be within 3 millimeters, much better than the radiologist. Right? Much better than the radiologist, only 3 millimeters the best. But we can go even further than that. Okay? Anybody wants me to explain that again? Yes.
For the case just now, the way you know it's from right RIMLF is just because it's like a video, or you can
Yes,
tell.
you're right.
So you can know.
Yes, thank you. Good point. Sorry, I'm sorry. There are a few other things, other points, but we look for associated. We know it's a unilateral lesion, but whether it's right side or left side, we need to look for other features. In this case, the patient in left side of it. And left side we lost because this is a top rostral midbrain lesion, terminal part. Okay, so I'm going to stop now and summarize what we have learned. So we realized the eye movements fairly straightforward in the sense that if you draw a diagram, you can work out the problem in the eye. Okay, but more importantly, the underlying networks rely on a few things, right? The nucleus and supra and prenuclear influence. The supra is the frontal eye field. The prenuclear influences your vestibular response. Okay, then your Goda neuron is prenuclear because it controls how the sixth nucleus, the third nucleus, the fourth nucleus must fire. By putting on a first gear. But Goda neurons alone not enough. There must be theta neuron. The theta neuron is another prenuclear influence, and most of the time it's coming from the cerebellum. The horizontal and vertical gates are identical in pattern, in architecture, but different in location because one is in the pons, one is in the midbrain. And there are additional challenges because of bilaterality, we need a connection system. And secondly, because of the effect of gravity, it's much easier to look down, therefore there is some redundancy for uptake. Okay? So now we'll address the gentleman's very important question. So you were saying just now, for a lesion in the stellate neuron, right? What will happen when the patient looks up and down? Right? Okay. So, if let's say my cerebellum is not working, my frontal eye field will send a signal to both my RMLF, my gozine neurons, will both working, will go up, right? Then, but the stellate neuron is not working. So what's going to happen? Down, right? Slow phase down. Then, boom, slow phase down. Boom, slow phase down. Okay? RMLF is not working, so cannot look down. So when I ask them to look down, okay, can look down. Sorry, my RMLF is working. Sorry, can look down, but my stellate neuron is not working. So what's going to happen? Boom, boom. So when I look down, it's downbeat. When I look up, it's upbeat. But because both sides are affected equally, because the problem is that stellate neuron, there is only a vertical component, no torsional component. You understand? Because it is not a region in the stellate neuron. Right? You see, your point is, your question is very brilliant question. Better that you may even realize that, because if it is a lesion in the gozine neuron, okay, especially if it affects one side, maybe I shouldn't go into it. You will get a torsional component. It says the stellate neurons in the cerebellum is affecting both sides equally. So they are just like when I say concyclic enough, they can cancel each other out to some extent. So a case affected because the torsional component is equal out. So it's only the vertical component. So you'll get a pure up and a pure down between the segments, but case in both. Okay. So to give you a taste for the next lesson, how is this nystagmus different from this nystagmus? Okay, so this patient, or maybe I'll give you a better example. What do you see in this lady? It's upbeat nystagmus, right? Similar to the patient with iron ore to some extent, but that's much more. Now, is this the same as the stellate neuron problem? No, because in stellate neurons, it will be gaze before. When I look up, be down. Look down, be down. Look to the left, be to the left. This one is primary position upbeat. Primary position upbeat. So it's not upbeat nystagmus. Okay, and we will discuss this at the next episode. Okay, you want to take over? Yeah, you wanted a question. Yes, ma'am. Sorry. Yes. Yes, to some extent, but it's a diffuse function in the vestibular cerebellum, the more primitive part of the cerebellum. So it's a diffuse function, and therefore it more or less affects it. But later on, you will find out that, in fact, I shouldn't give away that. But yes, your answer is most of the time, so you won't really see it. But because, oh no, maybe I understand what you're saying. So it is a diffuse function, but let's say you have a unilateral stroke, right? You often see that there is asymmetry. When you look to the side, it's more big. So the asymmetry is based on the fact that one side is affected so badly compared to the other side. So the stellate neurons are reduced more on one side than the other side. So therefore, there will be some for focal lesions. But for diffuse lesions like cerebral ataxia, phantom toxicity, both sides will be affected equally.
Thank you. I learned a lot. That was great. The terms used is helpful because when you describe it like stay there versus the go neurons, I've read it so many times, it's really hard to get that nuance. So it's a great lecture. I'm glad you guys are getting it. And it helped me put things together better too. So thank you. Okay, so we're going to kind of switch over a little bit. Now we're going to talk about afferent. As we said earlier, afferent relies on our vision, color vision, pupils, and confrontation fields, which you all know how to do now because we went through those skills. So using those skill set, your superpower, essentially, you're going to become a neurologist that knows how to look at neuro-ophthalmic problems. So my question to you is this case, keep in mind, is this in the optic nerves or is it in the brain? And how do we know? This is a patient that's 49 years old. He's a man. He came because he says he cannot see clearly in the left eye. And he says it very specifically, it's in the left eye. But you tell him what's going on. So 3 weeks before he came to our setting, he was reading a book and he rubbed his right eye and he thought, gosh, I can't see through my left eye. I never noticed that because you keep both eyes open all the time. So how do you know? He went to see an eye doctor outside of our university system who thought, yeah, the left eye visual acuity was down and there were some visual field abnormalities. So keep that in mind now. And on the day he came to the eye clinic, he said, you know, still my left eye cannot see very well. The right eye looks good. So still very consistent, something going on in the left eye. His history, he's presbyopic. He's 40-something. That means he can't focus up close unless he wears reading glasses. All of us will face that. Welcome to humanity. Medical history, he has high cholesterol. And he has a motor vehicle accident about 30 years ago, but really nothing substantial. He's not taking any medications. And you notice my history is pretty extensive because this is the part of neurology we focus on, is the history. We really need to know our patient well. He's an electrical engineer. He used to smoke, but he quit 2 years ago, tobacco, a pack a day for 30 years. His family history, his mom has multiple myeloma, which is a type of blood cancer, and then bladder cancer in his aunt. So when he came to the exam, this is his exam. I'm going to help you diffuse this. You've seen this before. In the right eye, he's 20/20. Left eye, 2200. You would agree with me, that's not great. And what that means is that compared to his right eye, he has to move up to 20 feet to see the exact same thing that the right eye can stand at 200 feet and see. Does that make sense? So that's the difference between the acuity. His color vision, he's normal in the right eye, but left eye, he's 2 out of 8, so definitely abnormal. But his pupils are normal. And the rest of the exam, intraocular pressure, all that was normal. So I'm going in the perspective of an ophthalmologist here. And when we look at the optic nerves, I showed you optic nerves earlier, and so you're going to participate with me and say, you know, compared to an abnormal optic nerve, is this nerve flat? Is it round? Is the color normal? I think the screen up there is not normal, but I just take my word for it. The color is normal. So I see pretty normal optic nerves on either side, right? So what is it? Is it in the nerve or in the brain? How do we know? Well, his visual acuity was abnormal. That sounds like it's in the nerve to me. Color vision's abnormal. That sounds like it's in the nerve to me too. But the pupils are normal, so it didn't really help us there with the pupils. And sometimes as your neurologic exam goes, some exam findings aren't helpful, but you take it with the clinical context. So at this point, can you tell if it's in the optic nerve or it's in the brain? And I would say, you know, my thoughts are right now, looks like it's in the optic nerve, but I need more information. And what's missing? Remember our confrontation fields. That's going to be very helpful. So you know now how to do a confrontation field, and you found that in the right eye, that temporal area was affected. And you did the left eye, and he can't see anything, no matter what area you showed the fingers. So there's your confrontation fields. Remember yesterday we showed those patterns of localization and where it occurs? This visual field if you recall, is called a junctional visual field. And a junctional visual field helps you localize to a chiasmal lesion, a midline lesion. It may not necessarily be exactly at the chiasm, right? The chiasms where they cross, but indeed it's going to be in that same area. So you see the little X there, that marks the spot. Well, let's prove it. How do we know? The workup, what's the next step? Well, in our setting, the next step would be, when I see something like that, I would want to look at the brain and see if there's something in there. So I ordered an MRI. And indeed, this patient coming in, noticing that the left eye he couldn't see all of a sudden while reading, turns out he had a pituitary tumor. And it was quite large. So that pituitary tumor is pressing on the chiasm. So if you look at the, let me go back here. So the nerve is here. If you can imagine it coming in here, here, and here. As it comes in here, joins together, half of it will cross over, the other half stays this way. And so this area here is where that chiasm is. And the pituitary is actually from the bottom. And that pituitary, when it gets large, it moves up because that's the only space that it has. It can move outward too on either side, and that causes a different problem. But in this case, it is moving up and pushing against the chiasm. And so if you have another view, that tumor is pushing up all the way. This is where the chiasm is, right here. That's where that nerve, where it joins together. It's pushing it way up there. So those axons, remember our axons? 1.2 million axons, the stems, they're pushed really well. And what happens to those stems when you push for a period of time? You're going to squish it. And so you start losing some of it. And that's where the vision loss came from. So this patient actually went to neurosurgery and had it removed. So he had a transsphenoidal through the nose. They go in and they clip it out and they take it out. And very well done after. This is the visual field before. After the removal, that's the visual field after. So we've saved vision in this patient by detecting it just by looking at the 4 things I asked you to look at. Okay, so that can be done in your setting. Now I realize as a neuro-ophthalmologist, I have other tools that helped me, but you still have this capability as well, knowing what you know today. Okay. All right, so as I said, this was a non-functioning pituitary macroadenoma, which caused that scotoma, junctional scotoma. All right, so I have a few more cases. Do you want to take over for now, or you want to go? Yeah, that's fine. Sounds good. Yeah. So I have more cases to come, but we're gonna exchange slide.
Okay, so we will finish off this, and then later when we go for tea, please bring your food back in so that we can continue. So then we can, because there's already a lot of food here. Okay, so I'll just introduce one of them. So this man has got primary position downbeat nystagmus, right? So primary position downbeat nystagmus. So look carefully. It's a bit confusing for downbeat, but it's primary position downbeat. Okay. So why would that happen? Well, very simple. Because like I said, when you move your head left and right, that's the vestibulo-ocular reflex, right? You also have a vertical vestibulo-ocular reflex. Okay. The vertical vestibulo-ocular reflex tells you when I look down, I must go up. When I look up, I must go down. Okay. Now, again, the vestibulo-ocular reflex like this. Like this, left side, right side is the same. But for this, is there a difference? Yes, against gravity. There's a problem. Gravity makes this movement easy, that the eye can come down, and makes this movement difficult. So the brain is confused now. How can I figure it out? Because Right side is the same as left side, but up gaze and down gaze are not the same. Right? So what does it do? It evolves another pathway. Another pathway called central ventral tegmental tract. Okay? This is a tract that starts off. Now this one not very well described in the textbook because it's still a controversial tract, but we believe it exists. Central ventral tegmental tract starts from the vestibular nucleus, travels up the medulla. At the middle part of the pons, it crosses over, okay, and then it goes up to reach the third and fourth nucleus. To counter the effect of gravity continuously, because gravity is continuously pushing down, this one is continuously pushing up. So this central ventral tegmental tract allows the brain automatically to have the same system for up and down gaze because gravity is being taken care by central ventral tegmental tract. Okay, so now left right is the same, up down is the same. Up down is the same. Okay, everybody okay with that? So in other words, vestibular ocular reflex is biased, more difficult to go down because the eyes have to go against gravity. When it comes down this way, it's more easier because now it goes with gravity. So to prevent this from becoming a problem, we have evolved another pathway called central ventral tegmental tract that continuously counters gravity. So gravity is pushing down, this one is pushing up. But there is a problem. Why? Because when I do yoga, I go upside down. Now gravity is going in the same direction as the eye. So our eyeballs should be pushed up, pushed down. Right? When it doesn't happen. So how come? Because you see, normally gravity is pushing down, CVTT is pushing up. If I were to go upside down, CVTT is pushing up, gravity is also pushing up. So the eyeball should be pushed up. But it doesn't happen. Why? Because our friend, the master controller, cerebellum, is active. Because your CVTT cannot be uncontrolled because of this. In the past, when your monkeys swinging from tree to tree, sometimes we are like this, sometimes we are upside down. Right? Birds also, when they are flying, you go upside down, fish can go upside down. So we are always not straight. So we cannot have a central ventral tegmental tract that's uncontrolled. Somebody has to control it. And anything that needs to be controlled in the brainstem, our friend cerebellum is the best. So this is the pathway. Central ventral tegmental tract is controlled by a small area in your cerebellum called the flocculus. Flocculus. Okay, if you remember from anatomy, the flocculus is in the tonsils, not this tonsils, the tonsils of the cerebellum, right at the base of the cerebellum. Flocculus. So the flocculus, what does it do? It inhibits CVTT. It holds it back. It prevents CVTT from firing too much. Okay, but when CVTT needs to be active, for example, when the CVTT needs to be active? When the person is in an aeroplane flying up. You know the aeroplane, the jet pilot is going up. 3 gravity, 4 gravity, 5 gravity, 6 gravity. Right? Gravity is so strong. But his eyeballs will be pushed down, right? So why doesn't his eyeball get pushed up? Because the cerebellum will say, okay, let's release CVTT. Make CVTT stronger. Less inhibition. Okay, CVTT becomes stronger, so the eyes are steady, so the pilot can still fly. Okay, so when he comes down, the plane is diving, his eyes doesn't meet because gravity is in the same direction. The cerebellum will pull back CVTT. Don't work now. No need. Okay, so cerebellum is controlling it. But the effect, now the third thing you need to remember, flocculus effect on CVTT is inhibitory. Inhibitory. Okay, number 3 things to memorize. So far 3 things memorized, right? This is number 3. So this is minus on CVTT. Okay, so if there is a lesion, now I go and damage this. Just like we damage the 8th nerve, PPRF, now we damage the flocculus. What's going to happen? Gravity will be uncontrolled. because there's no CVTP to control gravity. So even at rest, the eyeball will drift down. And then I say, oh, why is my eye drifting down? Hook. Hook. Sorry, say it wrong. Say it wrong. Sorry. I mixed it up or vertical. Okay, coffee. Okay. So CVTP is not working. CVTP is negative, right? So CVT is too active now. Flocculus is not working. So CVTP is too active because remember this is negative. This is negative. Negative, right? So there's no control of CVTP. So CVT is too strong now. It's like a wild horse. So at rest position, it will slow phase. And then what happens? Boom. You bring it down to normal. Slow phase up, bring it down to normal. Slow phase up, bring it down to normal. Slow phase up, bring it down to normal. So where's the fast component? Fast component is always the corrective, right? Downbeat. So that's how you get downbeat. So it's as simple as that. Flocculus lesion causes downbeat nystagmus. Highly localizing. So when you see a downbeat nystagmus, you know for sure it's cerebellum, not in the brainstem. It's the cerebellar pathology, and almost always involving. So very localized, very accurate. Okay. So sorry I confused you just now, but just remember it's a negative thing, right? So if no more inhibition, CVTD is too active, so it goes up, slow phase. Correction, because you're a conscious patient, poof, comes down. Correction, down. Correction, down. So by now you would have realized that nystagmus is named wrongly. In the textbooks, they always name it by the fast phase. But the fast phase is your correction. All nystagmus, you realize fast phase is the correction. The pathology is slow phase. Right? Okay. So that's what you are seeing in him. Okay. Now, so what are the lesions in the flocculus? Well, the classic is disorders in the cervicomedullary junction. She has got an angioma in the cervicomedullary junction. If she was a younger patient, she could be a anal chiari. Right? Classic causes are down. Right? Or pathology. Or she could have neuromyelitis optica with a lesion in the cervicomedullary junction affecting the flocculus, because the flocculus is exactly at the foramen magnum area. You know the foramen magnum, the tonsils are just there. So not much space. So if there's a tumor, if there's swelling, if there is a anal chiari malformation, the flocculus gets squeezed, patients get downbeat nystagmus. So number one cause, always image the cervicomedullary junction. Number two, flocculus is part of the greater cerebellum. It's part of the greater cerebellum. So sometimes cerebellar disorders can start with the flocculus and spread. Like this man. Look at his nystagmus. Classically downbeat, right? Primary position downbeat. Not gaze evoke. Primary position downbeat. So he starts off with the flocculus. Okay, we image the cervicomedullary junction, no pathology there. But his cerebellum was starting to get atrophic. And so we worked him up for acquired cerebellar disorder and found out that he had cancer of the lung. So over the next few months, he started developing other cerebellar signs. So remember, flocculus is also part of the cerebellum. So you must remember other cause pathology in cerebellum. Okay. So what is the commonest pathology in the cerebellum? Phenytoin. Right? So you must remember phenytoin as a cause around it. Number two cause, Wernicke's encephalopathy, alcohol related. So alcohol related and anticonvulsants, they cause any nystagmus. Remember that. Any central nystagmus. So in the exam, you're not sure of the causes. If you say phenytoin, anticonvulsant, or Wernicke's, you'll be right. Upbeat, downbeat, evoke, torsional, anything. Pendular, all can be caused by anticonvulsants or but they don't just affect the flocculus, they affect other things. Okay, but they can manifest as flocculus lesion first, but examine the other. Okay, so in this case, he's got diffuse cerebellar disease from NTQ, but presented first with flocculus lesion. Likewise, we are discovering more and more. This is an important cause because it's treatable. Anti-GAD. Anti-GAD antibody, okay, it's a rare cause of inflammatory cerebellar disease. Rare. But all the cases I've seen, they often start off with downbeat. I'm not sure why. So when you see downbeat and then goes on to become cerebellar disease, you must think about GAD because like cancer, GAD antibody is treatable. In this case, the treatment therapy. The same antibody that the diabetologists do, except the titers are slightly different. We don't have to go into that. Okay? So, finally, we have a cause called idiopathic, which just basically means patients are pathetic and doctors are idiots. Right? So, this is common. Why? Because, okay, one more thing I want to mention. You notice that this man particularly, there is a downbeat nystagmus, but it's much more obvious when he looks to the side. So sometimes, including myself, I've mistaken this to be horizontal gaze evoke. But when you put him to the side and look from the side, you notice that then nystagmus is down. So be careful. We have made this mistake before. Because it's much worse on the side, it looks like gaze evoke nystagmus, but it's not. It's primary position downbeat. So primary position downbeat nystagmus, for some reason, which is not explained, it's like this. But when you look at the side, much faster. Look to the side, much faster. But you're not sure, you go to the side of the patient and look from the side, and you notice the eyeball is coming down. So be careful. Because I've seen, in fact, recently, a few weeks ago, my resident called me and said, gaze evoke nystagmus. When we look carefully, it was downbeat nystagmus. You know, so be careful. Okay. So summary. Treatment. So remove the cause. Look for cervicomedullary junction problem, anal chyri malformation. Look for cerebellar toxicity from alcohol, burning keys and cytopathy or inflammation. Look for paraneoplastic cerebellar degeneration, and look for GAD. After you rule out all these things, there will be a group of patients where they remain chronic. We don't know what it is, but they are often very disturbed. Why they disturb? Because when you see with your slow pace, right? Because now if I do a cut for you, all of you can do a cut from one end of the room to the other end. Do you see anything? No. You only see the first part and the last part. In between you don't see. But slow pace you are seeing all the time. So the slow pace component is very disturbing to the patient. So when the hook, they are seeing things jumping. The slow pace going up, the eyeball will do the opposite. So everything looks like jumping up and down. Okay? So this jumping up and down is very disturbing to the patient. So, and because the pathology is in the cerebellum itself, and there's nobody behind the cerebellum, no other person controlling the cerebellum. It is the father and mother in the family already corrupt. Nobody else can do anything else. Right? So these patients remain chronically disabled. So therefore, we use drugs. And these drugs in this order useful. This is a generic drug. You can get it. Okay, many generic companies do it, but because it's generic, the companies don't advertise so much. So you can go and get it. I'm sure you can find it somewhere. Usually, so it is a generic drug. Baclofen also generic. Clonazepam also generic. Okay, normally I start with this, and I add this, and I add this. Because they are so disturbed. They will keep coming to you, saying, doctor, not well, not well, not well. Okay? Then, in the next episode, we'll figure out why this lady has got upbeat nystagmus. You know, even though she's got upbeat nystagmus, you saw her mascara. Right? But in fact, her mascara is not very well applied, right? Because I can't blame her. Difficult to apply with the okay, so you want to, shall we, what's the time now? 9 o'clock is the tea break. Okay, shall we break and then you do the next one, then I will do this. So if you guys want a shorter, because we all have to finish by 12. So, and we still have a lot of snacks. So we don't mind continuing, but if you bring your food in, we can start earlier.
Okay, so brain versus optic nerves. Gonna bring our mindset back to that again. Okay. I have quite a few cases as I go along here. Some are a little longer, some are a little shorter, but that way we kind of see all the different ways in which you can diagnose someone who may have, whether it's an optic nerve problem versus a brain problem. So, you ready? This is a case about a 45-year-old man who really did not take good care of his blood pressure. His blood pressure is 180s over 100. He's been having headaches. That makes sense, blood pressure that high. And then suddenly he started to notice, about 4 hours before he came to the hospital, that he couldn't see through the left side. And initially he said, no, it's in the left eye. It's only the left eye only. And this is a very common thing that people misconceive, because when they see on the left, can't see on the left side, they think it's only in the left eye. So how you can reconcile that is you ask them, well, can you cover your left eye? And can you still see? And you'll notice, wait, I can see half of my vision, or I can see some of my vision. Or then we might cover the left eye, the one that he couldn't see, and notice that he also has problems in the right eye. So that's important to distinguish. But he believes it's only in the left eye. And he also, as he's walking in, he's been knocking himself against the wall or the door, because he doesn't see on the left side, and he hits his shoulder. So he's feeling pain in his shoulder too. So it's not weakness, but he keeps hitting himself on the left side. And he drove himself to our ER in that university. So as I said, how do you determine if it's only in the left eye? Absolutely, anytime people say that, they can be quite confused whether it's only one side versus both eyes. Have them cover one eye and check. Have them cover the other eye and check. Always on one and the other to make sure it's only localized on the left eye. And in this patient, I'll reveal in a little bit that indeed his vision in the right eye is normal. His vision on the left eye just a little decreased, but still within normal. 20/25 means he missed a few letters. His color vision in the right eye, he really couldn't see either. Actually, that was normal. He was not able to do it, but it was normal. And then his pupils were reactive. There's no relative afferent pupillary defect. And his extraocular motilities, the efferent side of things, was normal. So knowing what we know about visual acuities, we can say his visual acuity is normal, color vision is normal, pupils are normal. It sounds like the nerves are okay, yeah? So there's a few missing pieces of the puzzles, but for now, I don't know if you would agree with me, but I think that optic nerve is okay. I think everything is occurring behind the, looks like it's in the brain, in that territory that we talked about. And at this point, it can be anything. It can be a mass, it can be inflammation, it can be a tumor, and it can be a stroke. What about in his history can help you determine what that might be? The blood pressure, that's right. And then how sudden was it? It was about 4 hours ago. All of a sudden you noticed that. So what does that tell you then? More likely is it perfect. So indeed we did. So that happened early in the morning. She noticed that she had this throbbing headache in the occipital area. And every time she looks at her children's face, her husband's face, the nose has disappeared. And it's not blackout, it just disappeared. 2 hours later, she can see parts of the nose, but then there's this cloudy vision in the upper half of her vision, and possibly some tunneling of her vision, so peripheral constriction of her visual field. So far, I think you have something primed in mind now. Visual acuity, normal in both eyes. Color vision, normal in both eyes. Pupils, normal with no relative afferent pupillary defect in both eyes. Confrontation fields, normal. Okay. The optic nerve, when we looked at it, was also normal. So now what? Visual acuity is normal. Color vision is normal. Pupils are normal. Can you say it's in the optic nerve? Not likely. Confrontation is normal too. Where can we localize to? This is a little bit confusing. But if you do the confrontation fields right, unfortunately, sometimes it's not done correctly. So we neglect to do the central part of vision. And that's yesterday I talked about facial Amsler. So when you do confrontation field, you have somebody cover their left eye, you do finger counting in all the 4 quadrants. In order to check your central part, have them look at your face and say, can you look at my face now? What do you see? Can you look at my nose? And then after that, have them describe what they see. And in her case, what she'll do is she'll look at the nose, and she can't see the nose, but she can see everything around. I can see your eyes, I can see your hair, I can see your chin, but I can't see your nose. And you do it on the other side as well. And indeed, it shows up the same way. It's like, same thing. Your nose is missing. Why is your nose missing? That can be very discombobulating, meaning that they get a little nervous when that happens. Makes sense. So as a neuro-ophthalmologist, I do have another superpower. I have technology. And that visual field test. Have you guys ever seen a visual field test? Perfect. So a visual field test is a computerized test that's been used for decades now. And we have data on millions of people. We know what normal should be like. And it can detect thresholds at specific areas in the visual field in each eye. This automated visual field, there's different types, but the automated visual field checks for a static in different intensities, some bright, some less bright. We can use different sizes as well, but it's in the same location each time. It allows us to get very finite, detailed visual field defect. And we already know because she can't see the nose, that means that it's probably very finite. So let's localize that further. And indeed, there's that visual field. We have what's called the paracentral or secocentral. And you can notice that it respects the vertical meridian, right? And it's on the same side. Also respects the horizontal meridian, also on the same side as well. So where does that localize to? Do you think it's still in the optic nerve? Definitely not. You're more comfortable now in the brain. But where in the brain? So this is where I say memorizing where those locations are can be helpful, because if you recall, that area is more posterior in the posterior cortical area, the occipital cortex. So there is what I predict the lesion should be. And we can determine that even before we do neuroimaging at this point. And I suspect that area is going to be small too, right? Because the visual field is small. So here is her MRI. This is an axial view, T1 before contrast, and then the next one to that is with contrast. And that doesn't really show as much. We'll go further. And then as I move forward to different slides, this is a T2 flare. And indeed, you start seeing T2 hyperintensity at that occipital lobe, very small area. And there it is. This is restricted diffusion with ADC that actually discovered that she indeed had a stroke in that location. It's a small stroke. This is why it's only visual symptoms only. But it certainly changes things for her because she's young and she has a history of migraine. And in patients with migraine, there's high risk of ischemia as well, especially the small vessels. You can see that a lot of people who have migraine. I'm curious, anyone in here have migraine? Yeah? Okay, a few. Less than I expect, because in most places who are, as neurologists, in the United States, we find 90% of neurologists have migraine. The reason is because I guess we get very fascinated by this and we go into neurology. But I have migraine also, and when I've actually had an MRI, I don't know if anyone of you've had a brain MRI, but my brain MRI also shows these restricted diffusion, not in this location, but in the watershed area, in the microvascular ischemic area, and it's usually in the white matter tracts. So it's not uncommon. And I correlate this to patients who have hemiplegic migraine and migraine with sensory deficits. In fact, when I was in the ER, I had a patient, young lady, 39 years old, came in and said, you know, all of a sudden today I feel numb right here. It's the same spot, numb in my arm. And, you know, it's just numbness. She doesn't have weakness. It's just numb. When I touch that area, I don't feel it. And we trusted her enough because she has a history of migraine. we actually did an MRI on her as well to make sure that she doesn't have other risk factors for this and get her treated sooner. She did have a small flare hyperintensity in the homunculus where the arm is. And that was quite interesting to see the sensory change correlate to the MRI. So don't dismiss these. And as you can see, even with your visual acuity, color vision, and confrontation field, if you're focusing on the right place, you can find the lesion before that neuroimaging is done. And you can see further her lesion as we move forward. All right. Case number 3. This is a 37-year-old woman who reports that she has a change in her peripheral vision. So her side vision is affected somehow. That's how specific she is. So 3 days before she came into clinic, she had a headache before going to bed. The next day she woke up and she could not see well with her left eye. And her headache is getting worse by the day. She thought it would get better if she go to bed. The next day, she thought, well, my headache feels better. But on that left side, I can't see very well all of a sudden now. And so she presents that same day to our clinic and she says, I can't see on my left side. This is definitely new to me. Her history, she just has refractive error. She really doesn't need much for glasses. She does have a history of migraine. She's a paralegal, she's divorced, and she does not smoke or drink alcohol. All those things are important because of stressors, and as you know, alcohol and tobacco increases risks. So here's her vision, 20/40 in the right eye. She pinholes. Remember we talked about pinhole? She pinholes to 20/25. That means that vision decrease is not due to a neurologic problem, it's due to an eye problem, like a refractive error. In the left eye, same 20/25. And her color vision is normal in both eyes. And she has no relative afferent pupillary defect. So, what do you think? Nerve or brain? 2 choices. Who says nerve? Okay. No one. One. Okay. And then the rest must mean that you think this is in the brain. All right. So we'll get some more information then. You did the confrontation field. And so your confrontation fields show this is a left homonymous hemianopsia. Left because it's on the left side, homonymous because it's on the same side in both eyes, and hemianopsia, half of the vision gone, right? All right. So we go back to our scheme again and realize that in a homonymous hemianopsia, it's going to be behind the chiasm. And so I should expect something back there. Is it a mass? Is it inflammation? Is it a stroke? Is it something else? So we did an MRI. Nothing yet. There you go. So certainly she has a T2 hyperintensity there, and it's pretty significant. This was a left homonymous hemianopsia due to the right occipital stroke on this patient as well. So you can actually diagnose strokes before you even scan. And I will also tell you a story when I saw a patient in the United States as a neurology resident. We were on call, as I'm sure you are, in the hospital about 30 hours. And we get a lot of stroke codes. And the requirements for a stroke code is we act as fast as we can. If they come in within the 4-hour window, we have as fast as we can to get them the TPA to help remove the stroke. And I had a patient, he was 45 or so, came in with exactly that, nothing else, a hemianopsia. And within 30 minutes, we gave him IV alteplase. And unfortunately, it did not work. He did not recover his vision. But ideally, if you capture it within that time window, that you can reverse, and I've seen it reverse. The issue sometimes is that patients don't know they've lost their vision until something brings them to their attention, whether they cover one eye, whether they're looking at something and realize, oh, I can't see that area. Otherwise, they seem to be able to preserve and function okay. So that's the issue with vision loss related strokes also. But this guy, he very much wanted to convince me that it was within the 4-hour window. And in our case, if it is, we do give them alteplase. All right, so this is a schematic of what I was referring to prior. When it comes to visual field defects only and no optic nerve problem, certainly it's going to be in the afferent visual pathway from the chiasm back towards the optic radiation. And you can have anything from an ischemia to a, which is a stroke, hemorrhage, tumor, inflammation, or demyelination process that can occur there. And when you have lesions in the occipital lobe, it is most consistent to have what's called a congruous visual field defect, and it's homonymous. Congruous means that the image of the defect itself is exactly the same on each side and not irregular. And so in the absence of neurologic symptoms like weakness, numbness, and other symptoms, likely you're going to be able to isolate that to the occipital cortex. All right.
Thanks. So we'll come to this lady, right? So she has got upbeat nystagmus. So what's the cause for that? Actually, very simple, right? You understood CVTT, central ventral tegmental tract, is countering gravity. Okay, so if there is a lesion in CVTT, gravity is too active. So what happens to the eye? Drifts down, correction is pop. Drifts down, correction is pop. Drifts down, correction is boom. Drift down, correction is boom. Upbeat nystagmus. Okay, but the only problem with upbeat nystagmus is, unlike downbeat nystagmus, which is only at the flocculus, the CVTT is quite a long pathway, right? You saw the CVTT is quite a long pathway. So anywhere along the CVTT, the lesion could cause upbeat nystagmus. So like what you were mentioning earlier, you look for the associated signs. So this man has got an upbeat nystagmus, and as I said, the lids always follow vertical movements. So you're not surprised the lid also has a nystagmus. Okay, so upbeat nystagmus. The left eye is toast. So what does that mean? He's got a third nerve here. Okay, big blown pupil, complete ptosis. So left third nerve, upbeat nystagmus. So localization is midbrain. Okay, so he does have a cavernoma in the midbrain. Okay, cavernoma in the midbrain, just close to the third nerve, and cause a third nerve lesion, and it catches the CVTT as it's approaching it. So this is a midbrain CVTT. Earlier on, we saw this patient who had an INO. Remember? Here? Yeah, INO, right? Yes. But we also noticed that he's got upbeat nystagmus. Not very congruent, slightly asymmetric, but upbeat nystagmus, right? So then we asked ourselves, how come a lesion within the MLF shouldn't cause upbeat nystagmus by itself, right? It can, but in this case, we were thinking, is there another lesion? So if you think about it, this vertical movement, both for up and down, are traveling up the MLF. So MLF lesion should affect the vertical movements equally, right? So vertical view are equally, okay? So, and CVTT is outside the MLF. So we were wondering, could this patient, upbeat nystagmus, could be another lesion in the CVTT, and is the CVTT close to the MLF? So what we did was, we went and looked at the original pictures. So you can see here is upbeat nystagmus. Primary position upbeat nystagmus, right? Beating up. So we were thinking, as the CVTT is going up, going across like that, MLF is here. So could there be a lesion in the MLF that spread and also involved the CVTT? That's our theory. Okay. So But his lesion is only in the MLF. His lesion is only in the MLF. Okay? So we took the original paper that describes where the CVTT is in close to the MLF. Okay, so this is the original paper. If you look at the position, this is slightly front, this is slightly behind. Okay, if you look at this, both of them are pons. The MLF is here, MLF is here, but CVTT is here. When you look at his scan, there's a lesion in the MLF, but no lesion here. So how do we explain this? Upbeat nystagmus. So we told the radiologist there must be something else. Repeat the scan, but this time do closer cuts. And this is the next scan. Can you see it? There's a dot, exactly where the CVTT is supposed to be. Right? So again, we told the radiologist what to find rather than the other way around. So this is a pontine CVTT. Okay, so earlier on we saw a midbrain CVTT. Now it's a pontine CVTT. This lady also same thing, a pontine CVTT. Okay. So remember, midbrain, pons, medulla. Okay. In the medulla, one of the classic causes of upbeat nystagmus is Wernicke's. And the belief is that it affects it in the medulla near the area postrema. Area postrema is also affected in neuromyelitis optica. So it's a funny story because neuromyelitis optica vomit a lot and then they develop this problem. Wernicke's patients develop the problem because of vomiting and not eating well. So it's a chicken and egg story. So be careful when you see patients vomiting a lot, look for area postrema lesion, but also give them lots of thiamine because they may have either primary thiamine deficiency until you get the history or a secondary problem. Right? Their vomiting is primarily due to area postrema problem and then secondarily due to. So in summary, cerebral CVTT starts in the medulla, goes up the pons and goes to the midbrain. So anywhere along the line, the patient can have a lesion in the CVTT and cause problems that are upbeat in nature. So how will you know that? One case, you saw the third nerve associated upbeat, so it must be midbrain. Second case, INO with upbeat, so it must be pons. Last one, we believe that the localization for Wernicke's is in the area postrema medullary area, and that's why they have upbeat nystagmus very prominently. So that's a medullary cause. So unlike downbeat nystagmus, which goes to only the flocculus, here you have to be anywhere along the brainstem. Okay, and you have to look for associated signs to decide which part of the brainstem. Okay, so it's a brainstem pathology. But the good news is because it's brainstem pathology, the cerebellum is active. So the flocculus is working, right? So if CVTT is injured, what does the flocculus do? Less inhibition. Release the control, make him stronger, right? So the cerebellum will do a lot of things to compensate. So very rarely do you see patients with upbeat nystagmus coming to you clinic after clinic for many years. In fact, very rare because it disappears. Almost all the patients I showed you, few weeks later, gone. Because your cerebellum can compensate for it. As opposed to downbeat, which never goes away, so they will accumulate in your clinic year after year because they never get better. So downbeat nystagmus, you need to give medicines to make them better. But upbeat, often treat the underlying cause and wait, often they get better. If they are symptomatic, we can use the same drugs. Okay? So in summary, remember that there's an accessory pathway which is not well described in the textbooks. This is the reference if you want to find the original paper that talked about it. This additional pathway starts from the vestibular system, goes up the medulla, crosses at the central tegmentum, up the medulla, up the midbrain to the third and fourth nerve. It is tonically working against gravity, but inhibited by the flocculus. So when the loss of inhibition due to flocculus lesion will cause downbeat nystagmus, upbeat nystagmus is anywhere along the CVTT pathways. You look for associated features. Okay? Okay, so you want to do the next one? Yeah.
Back to, is it nerve or is it the brain? So one of the things that we see often in neuroophthalmology is that the optic nerve is affected somehow. And often it will look edematous. So as you can see here, this is not flat. The edges and margins not very clear. The color may be a little off. There's some congestion. Looks like it might be elevated. So hopefully you'll agree with me. This is not normal looking. And it does look like there might be some swelling there. The question then is, what's the cause of the swelling? Many causes. It can be ischemia. A stroke to the nerve can do this. Anterior ischemic optic neuropathy is one common one. Optic neuritis can look like this. A central retinal vein occlusion, that's more of an ophthalmic issue. But optic nerve tumors, orbital tumors, tumor in the eye itself, pushing on the nerve, can do this. Genetic hereditary conditions, such as Leber's hereditary optic neuropathy in the acute phase, can do that. And then one of my, I have an interest in this, which is called radiation-induced optic neuropathy. Patients who've received radiation to the brain and optic nerve can cause swelling of the optic nerve. All right. So in the case of a patient who has swelling, I'm going to show you, is this nerve or brain? This is the patient. And hopefully you will say that this does not look normal by any means. What can we say that's not normal? You can't see the margins. It looks elevated. There's a lot of streaking of blood along the nerve fiber layer. And you really can't see the blood vessels coming from the center going out. Those are all abnormalities. And I think I'm reading your mind right now to say that does not look normal and looks swollen. So it is. This patient that came in then with this optic nerve had vision of 2200 in the right eye, 20/20 in the left eye. All right. Color vision is abnormal in the right eye, normal in the left eye. And here's the visual field defect of that eye. It's a constriction of visual field. So, is this in the nerve or in the brain? Who says nerve? A lot more. I agree. Consistently now, I think, this looks like it's in the nerve. What if it happens in both eyes? They look exactly the same, like that. What do you think? It can be the brain, right? So it can be the nerve too, if it occurs in both eyes. Ischemia can do that. But I think what's important here is to recognize when you need to get neuroimaging. Because if you see this and it's in both eyes, more than likely you want to see that brain, make sure. So you want to get an MRI on that patient, right? And this is what this exercise is about, is to determine when this is urgent and when for you to get that neuroimaging and when you can wait and say, oh, well, we'll see you in a month, we'll get it eventually, right? But would you wait on this patient? Hopefully not. If this was my sister, I don't want you to wait on her. I want you to do something about it. So she did get imaging. And indeed, this patient has a tumor compressing right on the optic nerve, and it's only in that right eye. And that's what caused the vision. So, all right. So there's your pressure that's behind the eye, not necessarily in the brain. It's still optic nerve. Questions? Yes. You should, if there is a visual symptom. you should always ask for orbital MRI. Why, right? The reason is that with orbital MRIs, the sequences are thinner, so you can see the optic nerve better. And they suppress all the fat that's in there. If you look at brain MRI, you can still see the orbit, but it doesn't suppress all the fat, so you can't see the detail. So if you have a tumor that's wrapping on the optic nerve itself around it, you miss a lot of that. If you get inflammation that just causes enhancement, you'll miss all of that. So in patients who present with vision loss, asymmetric or both, you should get MRI brain with and without contrast and MRI orbit with and without contrast. The thinnest section that they can cut, whether it's in the brain or in the orbit, it's about 0.7 millimeters right now in the United States. Most places are about 1 millimeter in thickness. Most MRIs are cutting about 3 to 5 millimeters. So you're going to miss a lot. That nerve is gone. Remember how the diameter of the nerve? 1.5 millimeter. You're not going to see it if it gets cut in between there. So you want to make sure you get an MRI orbit. You're welcome. All right. So this patient here, this presents with a nerve that looks mildly edematous, not like that last patient that you saw with all the things coming out at it. But you can tell subtly, right, up there, that you can't see the edges of the nerve very well. So the margins are a little, we call it obscured. It's blurry. And if you look at the bottom one, you can see that the vessels kind of look strange. That blood vessel, there's a little curly Q right on it, right there. You good with that? So this is a finding that's actually very common. If I tell you that the vision in the eye is 2100, color vision is down, there is a relative afferent pupillary defect, what would you say? Optic nerve problem, yeah? And so indeed, this person has a meningioma on the optic nerve itself. And so you do need that MRI orbit to see this, because if you don't, you actually will miss it. You see that, we call this tram tracks. You see the little linear on either side. That sign is called tram track sign, and it's very specific for meningiomas. So we look out for that as well. All right. How about this one? Is this in the nerves or in the brain? So both optic nerves are affected. Yeah, I see you saying that. So it sounds like you want to get an MRI now. Yeah? Okay. Let me give you some more information. So this patient actually, when we see optic nerve edema in both eyes, our concern is that there's something behind the eye pushing forward, and it's usually pressure related. And in the United States, there's a condition known as idiopathic intracranial hypertension. Do you have that common in Vietnam? I have a feeling not. The reason is because it's highly related to obesity. It's not always the case because there are other things that can prompt it also. But that's the most common, is due to obesity. And so I would imagine that there is less obesity in the United States, in Vietnam, and more in the United States. It's not a good problem to have. I wouldn't want to brag that. But that's what we look out for. But in order to look out for that, we have to rule out other causes. And there are other causes that can kill a patient, right? So if they have hydrocephalus, if they have a tumor, meningitis, encephalitis, a subarachnoid hemorrhage, certainly. Trauma can induce that. Any AV malformation that's high flow, so if you have an artery and a venous system connected together and is pumping blood on that venous side, it's going to bulge, right? And it's going to cause bleeding. Any venous obstruction, and then lastly, any medications that can induce and trigger increased intracranial pressure. So those are things we look out for. So in this case, this is a 65-year-old man with confusion, headache, and double vision. So we have now a little bit of efferent involved. His vision is normal. He's 20/20 vision, even though his nerve looks the way it is. Don't get distracted right now. Double vision is present. Color vision is normal. And his visual field, he has this what's called an enlarged blind spot. What that is we all have a physiologic blind spot, and it's taken over by our optic nerve. Because the optic nerve doesn't have photoreceptors, it's not going to sense light coming in. So you'll see that spot in that visual field, and it's a typical size. But it can certainly get larger if something happens to the nerve. And in this case, that's what we're representing, is that the nerve got larger and therefore the blind spot got larger. Okay. Questions? You guys are following me. We did an MRI on this patient, as you can imagine. And so indeed, this patient did have increased intracranial pressure, not due to idiopathic intracranial hypertension, but actual tumor. That tumor caused enough swelling in there to push on the optic nerve. And therefore, we started seeing optic nerve problem. But why did that patient have double vision? The tumor was not where the sixth nerve was, right? Remember where the sixth nerve comes out? It's where the facial colliculus is, at the pons, going forward. So there was no tumor there. I can guarantee it. Why do we have a, well, let me show you what he had. This is the double vision. And it's caused by abducens palsy. And in this case, the reason why someone would develop this type of double vision when you have increased intracranial pressure is because the pathway of the sixth nerve travels in this little area in the floor of the middle cranial fossa. And anytime you have a mechanistic pressure on it, a number of things can happen. One, you can squeeze the blood supply to it, so you can have ischemia, possibly. Or you can just directly press on it and compress the nerve itself. And that can either cause it to stretch or compress, and then it causes demyelination, then it doesn't function anymore. So you can develop that double vision. It's called a non-localizing sign because truly it can be, that pressure can occur anywhere and it can press on that nerve. In fact, it can occur also in low pressure situations. So what happens when you drain too much fluid sometimes, or some people actually tend to have low pressure. You've heard of normal pressure hydrocephalus before, or patients who have a dragging or sagging brain. What can happen is that it then causes the stretching of the sixth nerve as it's coming out from the pons and it reaches towards the clivus. And so in this area, let's just say if you have pressure pushing this down and this sags, right, it pulls on that nerve that's coming out and stretches it to the point where it doesn't function anymore. And so you then develop a sixth nerve palsy that way too. So that's why it's called a non-localizing sign, because you really can't localize exactly where it's happening, but it's in the pathway of the sixth nerve itself. And that can be brought on by both high pressure and low pressure. All right, so that's more of the anatomy. Okay.
Okay, so I'm going to change gears a little bit. And so that you don't get too bored, I'm going to give you a different dish to just cleanse your palate. So we're going to talk about cranial neuropathies that are relevant to the eye doctors, but as neurologists, of course, it's relevant. So what's wrong with him? He's got ptosis of the right eye. Okay, so again, if it's ptosis, you ask yourself, what are the pathologies? Well, it can be a local muscle problem, like trauma and things like that, but usually not an issue. It can be neuromuscular junction, myasthenia, or nerve. But remember, there are two nerves that can cause ptosis. One is the third nerve, the other one is your sympathetic nerves. Okay? So, now remember the zebra, and I was telling you about a few days ago. If you want to differentiate a horse from a zebra, don't talk about the forelegs, don't talk about the hoofs, don't talk about the fact that they eat grass. Don't talk about the fact that they both gallop. Think about the black and white stripes. So all four conditions here cause ptosis. But the main thing that differentiates between the three of them, the four of them, is the pupil. So in neuromuscular junction, pupil must be normal. In Horner syndrome, it must be abnormal and small. In third nerve, it can be big or normal. So in this particular case, what do you think is happening? It's normal. So it can be myasthenia or a pupil sparing third. So what do we do next? We look for fatigability. Okay, so I'm going to show you how I test for fatigability. So fatigability must always be tested in a muscle that is supposed to fatigue. Okay, so at the end of a marathon, 42 kilometers, the patients are collapsing from tiredness in the thighs, in the calves, in the arm muscles, but they are not collapsing from ptosis. They don't have double vision. They don't have facial weakness. They don't have swallowing problems. They can drink water very easily. They are breathless, but not hypercapnic. They are breathless, but not retaining carbon dioxide. Their necks don't drop. In fact, their necks are straight. Even though other muscles in the body must be super tired. Right? So these are non-fatigable muscles, muscles that cannot rest for the rest of your life. They are always supposed to be working. So if you demonstrate fatigability in these muscles, it's very specific. If I demonstrate fatigability in her biceps, it may not be very specific. It just could be normal physiological fatigue, or she has weakness from some other cause. And of course, weak muscles will fatigue. So in that sense, eye muscles are very useful. Even if the patient is not symptomatic, we go to the eyes to look for fatigue. So fatigue of the lids can be done by asking the patient to look up. But for some reason, I find looking sideways is much more productive. Okay, so here I'm testing the eye movements. Okay, then I'm asking the patient to look to the side. And you notice straight away the right eyelid starts coming down. Okay. So, and then after that, you can take a picture and then you can put some ice in a packet, in a plastic bag. Don't do this because it's not worth the money. And then put the ice on the face about 2 minutes. Take a picture before and take a picture after. Make sure the patient can feel the cold, but if you're holding it in your hand, you're less likely to freeze the patient's eyeballs. So it's better for you to hold it in your hand. And then after that, take another picture. And you can confirm in such cases, dramatic difference. So you know for sure this is myasthenia gravis. So again, magical because you don't need to spend any money on test. You make a diagnosis at the bedside and to help the patient. Now, I want to just introduce to you some of the other signs that are useful. Cogan's eye twitch is a useful sign. So how do we do it? We ask the patient to look at an object like a pen, write down, and then we hold another object, just like saccadic testing. We ask them to bring up to this position at eye level. The eyelid should come up and stay there. So look at me. Come up and stay there. Now I want you to watch this lady's left eyelid, the right eyelid, sorry. When she's looking down and then she comes up, it won't stop there. It will do a few twitches. That twitch is suggestive of neuromuscular junction fatigue. Okay, so let's play it. Twitch. Twitch. Right? So that is what you look for. Okay. Now, sometimes some patients like her are so severe that is continuously twitching. So we call it a high hopping sign. But again, you notice for some reason, I'm not sure what the reason is. I find much easier to bring on fatigue by looking to the side. I do this also, but I often do this. And I can bring the fatigue much faster. See? It's starting to close. It's twitching all the way and then it's starting to close. Okay, so this man, we did all of this. Fatigable testing of his lids, eye movements. We did the eye movements. Sorry, fatigable testing of the eyelids. We did the Colpack test. We did the Cogan's eye twitch, all negative. That's why I didn't show this patient. I showed another patient. So negative. So it is not likely to be myasthenia. So could this be, can it still be myasthenia? Yes, still possible, but could it be third nerve? So let's see what are the eye muscles that are affected. So adduction is weak. Abduction is normal. Elevation is not normal. And depression is also affected. Okay? So these are muscles generally support, these are muscles of the third nerve, right? Adduction especially and elevation. So we thought this patient has a third nerve palsy. And because he is diabetic for 10 years, this must be diabetic third, right? Correct? Correct? Obviously, when I say that so simply, it is not correct. Huh? Okay. So this is an important clinical reasoning principle. I didn't say much about this, but as you become more mature in your clinical training, you must be aware of cognitive flaws or metacognition. That means how your brain thinks. How do you make decisions? Now, if I were to now suddenly, right in front of you, start coughing, in front of doctor, say I cough, and I cough out, and because he's a good student, he catches my sputum in his hand. Because the old days, the guru will do this, and then the students have to. Same for Chinese Confucius culture also, right? So he catches the sputum. He runs to the lab, looks under the microscope, and he finds acid-fast bacilli. Okay, so what's the diagnosis? I'm coughing out blood. He took the sputum himself, no mix-up. He saw it under the microscope, and it is AFB, without doubt. So what do I have? Tuberculosis. Right? So as a good student, he will knock on the pharmacist's door today, even though it's a Sunday, collect the 3 drugs for me and give it to me, because there's no reason to wait anymore. It's direct evidence. Direct evidence. But the fact that this man has got a third nerve and he has diabetes, is diabetes a direct evidence or circumstantial evidence? So do we need to translate the word circumstantial in Vietnamese? Circumstantial. Is there a word for it? Okay, so you have seen, maybe I give an example. You have seen movies, police movies, right? The murderer is seen to be killing. That everyone is watching him killing the person. Then he goes to jail, easy. But then there's another situation where the husband is walking out of the room, okay, and the policeman goes in and sees the wife is dead. So it could be that the husband killed, or somebody else killed and escaped through the window, and the policeman came out, the husband came out. So to implicate the husband, it's circumstantial.
Ý thầy nói là những cái mà mình nghĩ nó liên quan đó thì nó là những cái bằng chứng về mặt gián tiếp thôi chứ không phải trực tiếp. Giống như là cái tình huống mà ở Quan Tà họ cần bằng chứng thì họ cần bằng chứng trực tiếp và bằng chứng gián tiếp. Ở tình huống này là cái đái tháo đường nó chỉ là cái mình có được và mình kết nối với cái sự kiện này thì nó là substantial hoặc là những cái bằng chứng gián tiếp mà thôi.
Try my best. Circumstantial evidence, the policeman has to prove beyond a shadow of doubt. It's tougher work for the policeman. But if it's direct evidence, like just now, very easy. No need to waste too much time. You can straight away go to jail. But in the circumstantial evidence, you have to prove, okay, the husband and wife were fighting. He bought a knife the day before. He wants to take the insurance from the wife. You have to prove everything. And then along the way, if you find that, the murderer is right-handed, but policeman is the husband is left-handed, okay, cannot release the person. Because one piece of evidence is against it, right? So the same way, if diabetes is circumstantial, the burden of proof is on us, doctors, to say that it is the cause. Because 15% of our population in the community has diabetes. This is in the outside. If you go to the beach now, 15% of the people at the beach have diabetes. In the hospital, it's probably 50%. You throw a stone, you will hit a diabetic. Bounce off and hit another diabetic. And the person picking up the stone and giving to you is diabetic. Everybody is diabetic. So if that's the case, how do we know diabetes is the cause? Maybe it's just by chance. So the burden of proof is this formula. Okay, this was taught to me by my teacher actually. So I go around explaining a very useful formula. For any cranial nerves, you use this formula and you will get it right. Whether it's single cranial nerve or multiple. It's based on simple anatomy. That cranial nerves, except for the first and the second, start from the brainstem. So this man, if he has a third nerve, could this be in the brainstem? Yes, it could be a brainstem lesion in the right midbrain, and you can only know that by examining his limbs and showing that he's got no long track sign. I know you guys do it, but the ophthalmologists often don't do it. They don't push the slit lamp away and examine the limbs. So the second rule is that after the cranial nerves leave the brainstem, just like many of us, after we finish work, we don't go home straight. We go to the club. And the club, there will be doctors, nurses, friends from other places coming in. Then we have a drink, and then we go back to different homes. Right? So the same way, third nerve, fourth nerve, fifth nerve gathers at the cavernous sinus club. Second, third, fourth, fifth gathers at the orbital apex club. Then they go to the final location. But as they are approaching the final location, all of them must come in contact with the meninges or skull base. So meningeal disorders and skull base disorders often cause cranial neuropathies, and you have to actively rule it out. And it could be an obvious meningeal disorder like TB meningitis, or it could be a subtle meningeal disorder like leptomeningeal carcinoma, carcinomatous metastatic disease, or skull-based disorders like radiation to the head and neck, which is common in our region. A lot of our patients get radiation to the head and neck, and they get skull-based osteomyelitis. And skull-based osteomyelitis can cause various cranial neuropathies. And these are not apparent when the patients come to you. And finally, you must remember, once the cranial nerve exits the brainstem, it becomes part of the peripheral nervous system. So it's prone to peripheral neuropathy. But luckily for us, most peripheral neuropathies don't affect cranial nerves. The one that affects cranial nerves most commonly is Guillain-Barré syndrome, especially the type that we see in our region, the Miller-Fisher syndrome. Miller-Fisher is so much more common in us, and that particularly affects cranial nerves. So if you don't examine the limbs, you may miss this patient. So the burden of proof is this patient's third nerve, you must make sure no brainstem signs. Must make sure no fourth nerve. Make sure no fifth nerve, including corneal reflex. Make sure second nerve is normal by doing all the things that she said. Visual acuity and color and fundoscopy exam. Many ophthalmologists do this routinely, but neurologists often don't do visual acuity routinely, which is dangerous in this patient. Okay? Then you have to think about skull-based disorders, especially if they are subtle ones like radiation, carcinoma. Obvious ones, the patients will come to you with headache, vomiting. And then peripheral Guillain-Barré syndrome is often ascending, but I have at least 2 patients. I've diagnosed isolated 4th, isolated 7th, didn't examine them properly, rushed through the clinic. Patient went home. 2 days later, I get a call, twice at least in my career, from ICU, intensive care unit. Your patient is in ICU now, intubated. Do you still think it's isolated? Obviously, the patient then tells me, oh, actually, doctor, I had some tingling in my feet, but you didn't ask me. So I didn't say, and I didn't examine the lips. So, of course, we learn from all these lessons. So you can look at all these references. There's more discussion about this. So this patient, you have to examine the patients carefully along these lines, right? So let's see. Now, only after you examine all the 4 rules and you find there's nothing else wrong except for an isolated syndrome. That's why my teacher, his name is Prof. He calls it the 4+1 rule. Why +1? Because there's one more rule, and the 1 is supposed to mean isolated. So isolated third has got two classic causes. Two classic causes. One is an aneurysm in the posterior communicating artery. Of course, there are less common causes, but these are the two most important. And then, of course, your diabetic third nerve in the correct context. So, in other words, after you've done all the 4 rules, no brainstem signs, no third nerve, no fourth nerve, no fifth nerve, no second nerve, okay, no meningeal disorders, no signs of Guillain-Barré. Of course, you don't have to investigate. You just have to examine clinically at least. No Guillain-Barré syndrome. And then you realize it's isolated third. Then you ask yourself, okay, is the patient diabetic? Yes. Is it the right age group? If it's a 25-year-old patient, okay, even if the diabetes started maybe today only because you checked the blood sugar and it's abnormal, you'll be suspicious. Young and diabetes just diagnosed. Correct? So, only if it satisfies all these criteria, then you can say it's an isolated syndrome. And if it's isolated, it's these two. Now, in countries like where she practices, where I practice, and in many of your hospitals, these patients, these two possibilities are real. So what do? You do an angiogram, a CT angiogram or an MR angiogram, and rule this out. And then finally you say this is. So your burden is tremendous. First, a lot of clinical exam, and then after that you have to do a CT angiogram or an MR angiogram, and then you can label this. Now, that's in our countries, right? But let's say, when I told you, right, I sometimes practice in Africa and all that, where we don't have scans. No MR scans, no CT scans. Okay? We have angiogram, but the angiogram is done many, many kilometers away, 4-vessel angiogram. And because the radiologist does that occasionally, the risk of angiogram is 1% stroke. Significant. So you cannot order for every patient. So you have to think very carefully. So, but still, what do? We rule out brainstem cause clinically, meningeal cause clinically, cavernous sinus orbital apex clinically, Guillain-Barré syndrome. Then we come to this. Then we ask ourselves, is the patient old? Yes. Is the patient got significant long duration of diabetes? Yes. Is the pupil spared? Yes. Is it a complete third? Otherwise, yes. Then I will say, no need to send to the town for angiogram. But if I come here and say, no, first rule, second rule, third rule, fourth rule, nothing, isolated third, but it's like this man, partial ptosis, partial adduction deficit, elevation, depression, not severely affected. So it's a partial third. Even though it's pupil sparing, if it's partial third, can still be aneurysm. So what do? Even if this is Africa, we'll find an ambulance, put him in an ambulance and send him 200 kilometers away for an angiogram. Because it is still an important cause to rule out. So in other words, there's a lot of confusion in the medical textbook of pupil sparing third, medical third, without making it very clear that if you satisfy all the criteria, no other cranial nerves affected, in the right age group, in the right diabetic patient, pupil completely spared, but otherwise completed. Then you can afford not to angiogram the patient. But in most of our countries, where CT angiogram, MR angiogram are cheap, easily available, and very safe, there's no procedure involved. Then, even if there's a 1% chance of aneurysm, it's not right for us to take it because it's a cheap, easily available, safe test. So we should do it. But the textbooks are still talking about 10 years ago. Okay, but 10 years ago applies for places like Africa. So in that place, we apply it. But other countries, we do that. So in your place also, you should try to do CT. But if you're in a province and a patient really cannot afford, you can still follow the rules. Because the rules are fairly good, but you must follow strictly. Why is the rule so strict? Firstly, it must be an isolated. Diabetes never causes mononeuritis multiplex. Never. Okay, that's a wrong thing in the textbook. Okay, any textbook like that, please write to me. I'll write to the editors again. Seriously, never causes mononeuritis multiplex. It's a mistake. It causes mononeuritis simplex multiple times in your life. You can get Bell's palsy today, 10 years later, I can get third nerve. 20 years later, I can get sixth nerve. 50 years later, I can get peroneal neuropathy. Yes. But this is not mononeuritis multiplex. This is mononeuritis more simplex. That is allowed in diabetes. But people have studied this very carefully. Any patient with more than one nerve in a diabetic patient, it is not diabetes. There's something else going on. It's license-threatening disease. You will lose your license if you continue to say it's diabetes. Okay? Okay, so coming back to this. Okay, why are these rules so strict? Firstly, diabetes does not cause multiple nerves, so must be isolated. Secondly, diabetic third nerve is a ischemic third nerve. So if the nerve is like this, the vessel is in the center. Aneurysm presses from outside. The outside fibers are pupillary fibers. So if there's ischemia, the ischemia is like a penumbra. Not penumbra. It's like a solar pattern. So it goes centrifugally out, ischemia. So all the individual nerves inside the nerve gets affected first. If there's any sparing, it will be the outside nerve, which is the pupil. But aneurysm presses from outside. And because it presses from outside, often it catches the pupil first. But if the third nerve is partial, this rule doesn't apply. Only if it's complete, then you can say, oh, ischemia can be complete. But if it's partially pressing somewhere, then maybe the partial part has spared the pupil partially. You know what I'm saying? So this is not emphasized in the textbook now. Remember, third nerve, the medical third nerve rule only applies if it's a complete third nerve with sparing. Cannot be partial pulses, partial meteoritis. Because if it's partial, you cannot use the rule of ischemia. It may be partial because the compression is partial. Okay? So that's why we are so strict about this thing. But in our context, we don't need to be so strict because we are going to angiogram them anyway. To the MR or CT angiogram. We won't do the forward one because that will be invasive. Okay. So we don't want to make it so practical, so theoretical. So let's look at this patient. So he's got a right third. Straight away we know burden of proof is not there because it's not complete. Right? That's one thing. Secondly, when we examine him, rule number one already got problem. What happened to his left hand? He's drifting down. He's got a drift on the left, a pronated drift. Okay, now for you guys, it's very easy. No? You guys examine, but the ophthalmologists often don't examine the limbs. They don't examine the limbs and then they miss this, right? So right third with left, right? So it's right midbrain. So not neuro-ophthalmology, it's general ophthalmology. Yeah. So yeah, I know. Because I know neuro-ophthalmology examine, general ophthalmology. So this is a brainstem cause for it. So, and then now you would have noticed, some of you would have noticed, but didn't mention it out of politeness. This patient's head was also tilted. One eye up, one eye down. What's that? Q deviation. And we kept saying again and again, Q deviation is central nervous system again. So this got multiple signs to prove that it's central nervous system. And therefore, we told the radiologist to show us a lesion in the fascicles of the third nerve. You know the third nerve, you draw like it's like a Mickey Mouse here. It's the mouth of the Mickey Mouse, the eyes of the Mickey Mouse. It's the ears. That's the midbrain. That's how you identify the midbrain. Then the third nerve is here, and the fibers come out like this. Like this. You know, two sides come out. So as they're coming out, it's caught here. Can you see? So this is the real patient. And then the cerebral peduncle is here, so the pyramidal dysfunction is here. The third nerve is here. Okay? So this guy has got a stroke syndrome. He doesn't have a diabetic mononeuropathy. He's got a stroke syndrome in the midbrain. So he needs to be worked up for stroke. Okay? So you can see the third nerve distribution here. It starts here. It goes past the substantia nigra. Great nucleus, sorry. Then the cerebral peduncle, and then it travels up. Okay? Cavernous sinus. Now, I think I don't want to make it too complicated. So let's go to another patient now. Okay. Okay, so we use the same principle here. Patient looking up, looking straight, looking down, looking right, looking left. Now, one of the things that we eye doctors often use is that we use the reflection of the light on the iris to see what is the symmetry of the eye, rather than just using the white. So when you use the reflection of the light, you notice that in this case, the left eye is isotropic, right? The left eye cannot abduct, right? So that's a useful way to check for symmetry. So you must draw the eggs, okay? And the eggs will remind you that it's not straight away a sixth nerve palsy, because many of you would have jumped the gun and said sixth nerve palsy. And 90% of the time you're right, and that will make you keep feeling that you're a good doctor and continue to perpetuate our bad habits until we meet the 10 patients who have other causes. Like this, right? Thyroid eye disease, orbital mets can give rise to abduction deficit of the left eye. So you need to actively rule it out. Likewise, myasthenia can cause abduction deficit of the left eye. Okay, so you have to actively rule it out. Only after that, then you say sixth nerve. If it's sixth nerve, again, you cannot just say sixth nerve and walk away. You must use the 4 rules of the sixth nerve. So, first rule is, could this be in the brainstem? Right? So, if it's in the brainstem, you can see that it's very closely associated with 7th nerve and contralateral pyramidal signs. So easy for you to screen. You don't have to do much exam. Just do the rest of the cranial nerves and just put the arms like that. You know, pronated drift is a super sensitive sign for pyramidal dysfunction. More sensitive than actual power testing. So a patient with a pyramidal dysfunction on one side will always do this. Right? Down and in. Right? So look for that. Then, second rule is orbital apex cavernous sinus. So remember to check second nerve carefully by actually doing pupillary exam, RAPD, swinging torch test, visual acuity. If you have time, do color also. And then I have had a patient actually, I labeled as an isolated 6. You know, and then I managed as isolated 6. Then 6 months later, 3 months later, less than that, 2 months later, she came back. The 6 nerve hasn't improved. But then she started saying, I cannot see very well. Oh, I thought my heart started dropping. Then when I examined the eyes, actually visual acuity had dropped tremendously. Then when we went back to repeat the scan, there was an orbital apex nerve. But interestingly, the radiologist missed the mass in the first scan. Why did he miss? Because I didn't tell him what to look for. If I had found the subtles, because in the first admission itself, in retrospect, I'm very sure, she must have had subtle second nerve involvement. Subtle meaning she cannot notice it because of a double vision, she doesn't notice it. Because she's not looking with both eyes equally, she won't notice that this eye is slightly there. But if I close the normal eye and check a color and a visual acuity, there would have been a drop. Once there is a drop, or if I do a swing torch test carefully, if there was a drop, then I would have told the radiologist, please look at orbital effect. Nothing else, you need to look at nothing else. Because second nerve plus 6th nerve can only be one location. Or orbital effect, right? Orbital effect in front, right? Okay, so please look there. Right? So, and then you would have found it. So radiologist eyes activated by our brain. So we have to tell them. In this case, I didn't serve the patient well. Why? Because of what I just said. You know, we don't follow the system. Sometimes we think we know what we are doing. If we don't follow the system, you're right most of the time, but not all the time. But we have to be right all the time, like the pilots, right? I think I gave the analogy. Pilots are good examples of professionalism. Because no matter how senior they are, they cannot take off the plane until they fill the checklist. Because they want 100% safety. 99% not good enough. Right? So for us also, we must have 100% accuracy when we're dealing. Because it's somebody else's life or limb. Right? So 1% is one person's life. We can go home and continue with our life, but the person's life is gone. Right? So we have to be very careful. So meningitis is important for 6th nerve because of the reasons Dr. Melanie was talking about. 6th nerve is very promiscuous, going very long distance, traveling through, okay? And in our context, nasopharyngeal carcinoma is a big monster, right? Say nasopharyngeal carcinoma is very common, right? And a lot of them present with isolated 6. The clue is conduction deafness. Okay, so and that's because they involve the base of the skull. So very important to look for that. And then of course radiation. Okay, and then Guillain-Barré syndrome. And then only after that, okay, but again I would say there's a burden of proof on us. Why is there a burden of proof on us? Because firstly, diabetic patients are common, so therefore you have to make sure that the diabetes is significant and the patient is old. But unlike the third nerve, here the burden of proof is slightly different. Why? Because if you look at the cavernous sinus, the 6th nerve is right inside, 3rd and 4th on the outside. So if you want, you can say it's like the clubs with the first person who goes there during happy hour is the 6th nerve. Then the others will come later. In fact, I have had patients like that. First week, 6th nerve, isolated. 3rd, 4th, 2nd comes later. Okay, so look out for that. Similarly, nasopharyngeal carcinoma, very commonly, if you don't check the hearing, it's isolated. If you don't check for lymph nodes, epistaxis, increased pressures, sometimes it's subtle. In a chronic state, the patient may not be complaining headache if you don't look at the fundus carefully. And sometimes we know because we only use direct fundoscopy is not as good as indirect to pick up subtle punctal edema. And then chronic meningitis must always be careful. Carcinomatous meningitis. Yeah? And the clue that I often use is check the hearing carefully because almost all carcinomatous meningitis affects the hearing also. Okay, so another quick example. This woman has got abduction deficit of the left eye. Because you are now very careful doctors, you'll be thinking about orbital disease, muscle disease first. And you'll be very suspicious in her because the left eye looks a bit swollen. It looks a bit red. Maybe the orbital content is increased because there is either thyroid eye disease or some kind of space occupying lesion or inflammation within the orbit that is affecting the eye from moving. Okay, so what can the ophthalmologist do? They can anesthetize the eye for us and they can pull the eyeball and move the eyeball. Okay, if the eyeball is able to move in the direction of weakness, then it cannot be a restriction. You all understand that? Very important principle. Huh? But we can't do it because we often cause problems in the conjunctiva. So we ask the eye doctors to help us. So because their hands are much finer, so they anesthetize the eye, hold the conjunctiva and then they move. If the eye can move in the direction of weakness, it's not due to restrictive eye disease. Because muscle disease is always restriction of the opposite muscle. You understand? It's usually not the lateral rectus affected. Medial rectus is restricted by thyroid disease, metastatic disease, inflammation, infection, or fracture. Okay? So they can sort that out. Is this myasthenia? Yes, we can give some tensilon, do fatigability test, ice pack test. Okay? All was negative. So we thought it was a 6th nerve. If it's a 6th nerve, we examined her brainstem. There were no brainstem signs. We looked hard for 2nd nerve, 4th, 5th, including corneal reflex. It's a must. Normal. She's got no evidence of skull-base meningeal disease, no lymph nodes, no epistaxis, no hearing loss, no headache, no vomiting. And she's got no limb symptoms in terms of weakness and numbness. But interestingly, if you look carefully at the eye, and on further questioning, she says, Doctor, I also hear a sound. So she actually has a carotido-cavernous fistula. It's a real patient, right? Then you'll be asking yourself, how come? Only isolated 6. That's the idea. And she's also diabetic. Right? So must be careful. So she has got a CC fistula, and further examination reveals that the blood vessels are all congested. CC fistula means cavernous sinus is a venous system. There's a carotid artery traveling through it. Now imagine, it's a very dangerous system, right? Carotid artery, the pressure is 150. The cavernous spine, the system, venous system pressure is much lower. So one day, because of whatever reason, there is a fistula. Then the arterial pressure gets transmitted to the venous system. The venous system becomes arterial. The pressure is transmitted forward to the ophthalmic vein. So all the blood vessels become very congested. eye becomes swollen. Okay, pressure is increased. So the cavernous sinus, the first nerve to be affected is the sixth nerve. So this is a treatable condition. Okay, it's not that serious, but it's a treatable condition that the radiologist will block off the fistula. But just to illustrate the point about what was I going to say? The point about not following the formula. Okay, and this one is not relevant for eye lectures because it's a facial palsy. Okay, but just to illustrate that many of you would have straight away jumped the gun and said this is lower motor neuron facial weakness, so this must be Bell's palsy. But you're going to be right 90% of the time, and therefore we think that we are good doctors. But 10% of the time will be something like this. This patient is HIV seroconversion. HIV seroconversion. This patient has got a mastoiditis with an isolated seventh nerve. Okay? So the point I'm trying to make is that if you use the 4 rules of the cranial nerve, both patients you wouldn't have gotten wrong. Rule number 1, could this be in the brainstem? Seventh nerve means it must be pons. So you quickly screen for brainstem side. Rule number 2, what are the clubs the seventh nerve belongs to? CP angle, right? CP angle mostly. Seventh nerve, right? Cerebellar contact angle. So you look for 5, you look for 8. Okay. Then after that, skull-base meningeal 7 disease. 7 is very important because remember internal acoustic meatus. Then middle ear, mastoid bone. So the second patient had mastoiditis. Another patient had mastoid fracture. Okay. So finally, Guillain-Barré syndrome, as you know, is a very common cause for facial palsy, and I've seen many cases presenting a face first, then the rest comes later. So must be careful. Okay. Just to point out another interesting case. Whenever you see bilateral 7, in your context, in my context, think of HIV first. Okay, even negative, call the patient back 3 months later for repeat test. Okay, HIV is the most important. Then Guillain-Barré syndrome will be well known to you in the next few weeks because he will go on to develop numbness, weakness of the limbs. Okay, bilateral 7. Okay, now this one I think you all saw yesterday, right? It was an interesting patient. But maybe I'll just skip that because I want to show you this patient. This one. This is a very interesting patient. I was in an eye hospital. This was Arvind in South India. You know the Arvind hospital. So anyway, they're very well trained eye doctors. So this patient was referred to the eye doctors for tarsorrhaphy because she has Bell's palsy and her left eye is inflamed from the exposure, so she's going to go blind. Doctor, please stitch up eyelids so that she will go blind. That's the referral from a neurologist. But my friend, ophthalmologist, he's a neurophthalmologist, very smart guy. So he straight away said, Uma, you have to see this patient. And I said, why? Because she's smiling. That's what he said. Actually, he said. Then I said, why? His name was Mike. So I said, Mike, why are you so cruel? Why can't patients smile? You know, maybe she's just not upset about her face. He said, no, she shouldn't be smiling because her cornea is completely gone. Cornea is completely gone, which means it must be super painful. But she's smiling. You know what that means, right? The cornea has got no sensation. So if cornea has no sensation means it's not just isolated 7. 7 plus 5. Right? So that's why he said, no, cannot be Bell's. Please see. But the neurologist made the same mistake that all of us make. 90% of the time is Bell's, so we think it's Bell's. Diagnosis by the most common disease. So what did we do? We confirmed it. We couldn't do a cornea reflex because her cornea is gone. So we checked the sensation on her face. I'm talking to her in Tamil. So she says that your metal object doesn't feel cold at all here. Feels very cold on this side. So she's got facial numbness. She had mild hearing loss, and this is a useful sign, especially for ophthalmologists, because a lot of times you get diplopia, right? So this finger nose test is actually flawed because you have vision problem. So we like this. This one is actually taught to me by my teacher. So he calls it dyschronometria, because dysmetria is this side, but he calls it dyschronometria because you can compare both sides, put the hands like this, ask them to come to the nose like this. and then open, come back to the nose. Okay. Now, if one side has got cerebellar signs, you will be doing this. There will be tremor. You will come later. That's why it is chronometry. Hers is very subtle. But you can do it because you're comparing right and left. See that? She keeps missing the left side. So and this patient wasn't scanned because the neurologist said, Bell's palsy. Right? So we quickly put her back in the ambulance, send her back to the neurology clinic. I said, please scan this patient because CP angle is possible, but her history is very acute. So we have acute 7, 8, cerebellar. What syndrome is that? ICA syndrome, right? Anterior inferior cerebellar artery, lateral pons. Right? Yeah. So, but lateral pons often doesn't affect the pyramidal fibers so much. That's why she doesn't have pyramidal. So remember, ICA syndrome is PICA syndrome is lateral medullary syndrome. You go one floor above with the ICA syndrome. ICA syndrome is very similar to ICA syndrome. You get honors, you get 7, you get 8, sometimes you get 6 also, 5, but you don't get 9 and 10. Okay, and you have cerebellar. Okay, it's a stroke syndrome. So we thought it was a stroke syndrome, so we sent her off to the thing. I think I'm almost done, so we can pass over to. Yes. So in summary, whenever you see cranial nerves, in our case, we only dealt with the 3rd, 4th, and 6th. Well, I didn't deal with 4th, but basically the same principle. Before you call that 4th nerve, whenever you see a patient with 4th nerve, remember it may not be a 4th nerve. It can be a muscle problem, restriction, can be myasthenia, causing vertical difficulty. Then you ask yourself, is it 4th nerve? 4th nerve, is it in the brainstem? Is it in the cavernous sinus, orbital effect, any discovery, Guillain-Barré syndrome? If not, then isolated 4th. Isolated 4th can be either due to a ischemic limitation or decompensated. So just to explain for the neurologist, please correct me if I'm wrong, because this is something again neurologists often cannot deal with squints and all these things. So basically, when you're young, if you have one eye that's not aligned with the other, as you're growing older, your body adjusts. So for 4th nerve, your body will adjust by going to the opposite direction. Right? So your head will be always tilted. So if you look at your family photos, some people's head is always tilted one side because they have a mild 4th nerve from young. But they are well compensated. So one day, it's like your computer system got rebooted. They may have something or they have fever or something. And this brain gets confused. Forgot how to adjust. Suddenly the patient will start feeling double. So it's called a decompensated squint. So correct, right? Explanation correct? Okay, well, you guys can do more things to control it, right?
So like you said, the face, you can ask them to bring pictures of themselves when they're younger, and they can see that they have a head tilt or a head turn. Yeah.
You can continue while I quickly go and check up first.
Awesome.
Then I'll come back.
Okay. All right. So I really like how Uma talked about, really want to follow the formula. So my philosophy in practice is I trust everyone, but I verify everything. So anytime I have something that has been found or hasn't been found, I say, well, let me make sure I see the same thing they see. And sometimes what happens is I find things that wasn't found before. And that's really important because when someone comes to me, I want to be able to add to the patient's care. And wherever they've been to before, it's not uncommon for me to actually see my slide. Got it. Okay. Thank you. So it's not uncommon for me to sometimes diagnose or detect something that wasn't diagnosed before or diagnosed incorrectly. And it's no fault to the other person. Perhaps they didn't get the information I got when I see them after them. So again, I practice with that philosophy. I trust everyone. I think that everybody has the potential to help my patient, but I verify. And I do that to myself too. What happens if I've seen them a year ago and they might come back to see me? I trust what I've done, but I will verify the things I've looked at also to make sure that I'm not missing anything. And that really kind of puts me at a humbling place because you never know what you miss at the time that you've seen that patient. And I have also uncovered things that weren't uncovered before. All right, so moving on to additional cases on the afferent system. This is a patient, let me make sure I got the right one. Yeah. This is a patient that presented with some intermittent headaches. So this headache that comes and goes. And it's most prominent in the posterior side. They categorize this to 8 out of 10. So it's a good severity. And it lasts hours at a time. It's not something that's brief. And this can occur when they're waking up. They've been sleeping and they wake up with this headache. So that can trigger your thought process there. Not many things cause you to have headaches when you wake up. Concurrently and additionally, she also or he has this sound in the ear that sounds like shh, shh, shh. It's in both ears. And they noticed that while she was sleeping more the past few days or weeks, there's no nausea or vomiting. And sometimes this patient also gets double vision. So we visited earlier that double vision in some patients can be a non-localizing sign. So keep that in mind. Other than that, the history is really non-contributory. This patient is healthy. They weigh 160 pounds for 5'10". That's actually pretty good. Not considered significantly obese in America. Doesn't take medication, and is actually a 12th grader in high school. Her parents are divorced, and she doesn't smoke or drink alcohol. We still ask regardless of how young they are. And family history, there's a history of father having a benign spinal tumor and strabismus surgery. That means that they had a misalignment when they were young, and they had to do realignment surgery of the muscle to get the eyes to straighten out. So exam, right eye 2050, we tried to pinhole to see if this is due to refractive error, and it did not improve. Left eye 2025, that's baseline. Color vision is normal in both eyes. The pupils it's normal. No relative afferent pupillary defect. Confrontation is full. And the intraocular pressure is also normal. So what do you think right now? What speaks to a possibility of optic nerve problem versus a brain problem? What do you think? Visual acuity, do you think it speaks to that? I see some nodding, but I'm not sure what's nodding for. So do you think that visual acuity speaks for optic nerve problem or brain problem? Brain problem. And then someone is referring to the history. You're right. Paying attention to the history is very important because that can also help you to clue whether it's a brain problem or a nerve problem. But the rest of the exam doesn't really add to it, right? It doesn't look like it's nerve related. Perhaps it supports a brain related problem. Okay. So more information might be helpful. There's the optic nerve. Both eyes. Would you agree that they look edematous? Yeah. And there's some hemorrhages there. So yeah, it's something that's happening. It's either happening to both optic nerves or it's happening behind the optic nerves. Yeah. There's a grade system that's related to swelling of the nerve. You may be aware of this. So as a neurologist, we actually learned this quite a bit also because part of our neuro exam is that we also look at the fundus too. And this grading system is based on Dr. Friesen in Sweden. And when he looked at all the different ways in which the nerve swells, the severity of swelling, if the swelling is all around with sparing of one side, as you can see there, one area of the nerve is not swollen, that's a grade 1. Of course, 0 is no swelling whatsoever. Grade 2 is circumferential swelling. The whole nerve is swollen. But you can still see the blood vessels. You can still see other details of the back of the eye. Grade 3 is when one of the vessels is lost. So you can't track that vessel right there down at the arrow. You can't see it from where the vessel came out to the retina. So that is a grade 3. Grade 4 is when most of the major vessels are obscured and you can't see where it's coming from. Only when it's out in the retina do you start to see it. And in grade 5, it's pretty fulminant. You see a lot of swelling all around, some hemorrhages. And you notice that the color of the nerve on grade 5, it's brighter than the rest of the other colors. That tells you that there's some ischemia involved. So lack of blood supply to those axons themselves. That's a grade 5. So in this patient, we'll summarize, she's a young lady, not exactly obese, wakes up with headaches, has swishing sound in her ears. And for the past 3 months, headaches, normal pupils, swollen nerves. You think this is in the nerve in the brain. I think you all now agree it's likely in the brain. So she did get an MRI, and this is her MRI. So in the United States, the most common bias there is that this is a patient with IIH. That's the most common first thought. And that's where we need to verify, right? Because that's a bias that we have in our practice setting. You may not have that bias here because it's not common, but that's what we think about. But indeed, when we do this imaging on this patient, she certainly has something going on in where the cerebral aqueduct is. And indeed, she has a tumor there that caused hydrocephalus, which then caused swelling of the optic nerve, which actually was severe enough to cause decreased vision in that eye. So indeed, that visual acuity was caused by a central process, not necessarily a nerve-only process. Okay. So take-home message, new onset headache with papilledema is a brain tumor causing obstructive hydrocephalus until proven otherwise. So certainly you need to get an MRI of the brain with contrast to find that. Don't delay the diagnosis for that reason. Okay, so that was case 1. Case number 2, yes. Good question. So it's believed that when you have this increased mass or increased pressure in the brain, it can compress tissues, right? It's pushing on everything, including the optic nerve. And what's more compressible, the artery or veins? Veins. And so where do you find venous system in the brain? Your cerebral venous sinuses. And in particular, as it grows, it pushes on the transverse sinuses. And with the transverse sinus near the inner ear, when it flows through, it causes turbulence. And that's why you hear that psh, psh, psh. Good question. So we'll hear that too in patients who have any type of increased intracranial pressure. So that's a good history to obtain in a patient to keep in mind for a central process. All right. This is a 21-year-old right-handed man. He's a laborer. He works in labor jobs. And he noticed that his left side vision is lost. He can't see in the left side. It's a common complaint, often in the left side. And I keep saying left side, thinking it's the left eye. He does have a history of eye issue with the cornea, but that's not why he came in today. He has high blood pressure. He has a history of concussion. He played football as a high schooler. He got knocked a lot, so he had loss of consciousness. He doesn't take any medication. He still smokes. He does drink alcohol socially. He doesn't get drunk regularly. And his family history is non-contributory. So vision-wise, he's definitely decreased in the right eye, more so decreased in the left eye. Pinhole really did improve the left eye just a little, but not in the right eye. Amster grid, this is a test that looks at central vision, which is a grid with squares, and we're looking at the center part of the vision. That's normal. That's reassuring. We know now that the center part is normal. Color vision is normal. Pupils are normal, but he came with his eyes kind of dilated, so we didn't know if there's a relative afferent pupillary defect, but pupils are normal. Pressures are normal, and the anterior segment is normal. And we move straight to the visual field. So far, everything else is normal, and you see this visual field. What do you think? Is it central? Is it optic nerve? Okay. Okay. We look at the optic nerves. There's no swelling. Yeah. It's nice and flat. The color looks okay. So is it still the optic nerve? What do you want to do? An MRI. That sounds consistent. So, that visual field, I want to go back just a second. And what you might be thinking that this is optic nerves because the pattern, one is different than the other. It's not congruous, right? When we say congruous, it's exactly the same. But it is on the same side, wouldn't you say? So it's homonymous. One is half hemianopsia, the other one is a quadrant instead, but it's still on the same side. So that should localize behind the chiasm in the optic tract. That's right. So if we theorize correctly, then our image should show what we should see. And indeed, this is her imaging. She has this T2 hyperintensities in the medial temporal lobe. It's a good size. And it also enhances, it picks up contrast. And so indeed it's part of the visual pathway, but it's asymmetric because of the location. So it's not exactly congruous. Okay. So not bad. Now you can see the variation in visual field, but pay attention to the rules. Did it follow and respect the vertical meridian? Is it on the same side? And it doesn't have to be congruous, right? Here's another example. This is a 54-year-old man confirmed with metastatic melanoma. He had it resected. It was removed, and then he also received radiation, and he also received chemotherapy. He initially presented with headache, and he also developed a seizure that he didn't have before. And now you see that visual field defect. And so I'll tell you that there is something in the neuroimaging, but let's look at the visual field. Can you say that it's respecting the vertical meridian? Not exactly. And there's this very incongruous. Yeah, it's not exactly the same on either side as well. So it could fall either way, but the history might help you. And do you remember this pathway? So I would say, although there is a little bit of crossing over in the vertical meridian, he may have some other underlying ophthalmic reason for that. But baseline-wise, he actually has a homonymous defect that is not congruous. And indeed, what happened was he actually had a glioma on that side as well. So one of the fallbacks or the setbacks we have is that, whatever the textbook looks like, the patient doesn't read. So the patient doesn't come in telling you that's what I have, and it looks exactly like in the textbook. We want to have a flavor about these things. And one of the take-home messages I get from my attendings when I've learned from them is that often it's all in the history. So there's a phrase that I learned called the mystery is in the history. If you get enough detail, you can diagnose about 80% of the things that you look at. And talking to that patient, that visual field was flawed. But if you do a confrontation visual field, you may end up seeing it better. In fact, if you actually do it with a smaller stimulus, sometimes we can use a small white target or red target. You may actually pick that up better than even the automated visual field. So that's where your superpowers come in. I'm trying to remind you that regardless of what technology tells us, you really have to look at that patient and verify for yourself, and that gives you a better answer. Right. So homonymous hemianopsia localizes lesion to the area. Obtain an MRI of the brain with and without contrast. Don't miss and do not delay. You're just in time for the next one. Yeah.
Okay. So I'll do the lids because they're kind of complementary. So lids, okay, so what do you think of this man? Left-sided ptosis. So remember muscle, neuromuscular junction, nerve. Nerve can be either pupil or either third nerve or harness, right? So remember this. I remember this important formula. Maybe if you want to take a picture. We already discussed this. The importance of the pupil in sorting out the ptosis of one eye. Okay, and we already said how to examine for myasthenic ptosis. So that's a repetition. So Dr. Say is not here, so I'll skip this because this is not so important. Okay, because he wanted to show me a patient with a similar problem. Okay, so this is a real case. Okay, so now we will try applying this formula. The emergency department calls us because I think, like many hospitals in the world, emergency departments are too crowded, so patients can't get admitted. So we are rostered to go down and see the patient. So me and my resident went down to see this patient, and we saw this. Now, first I said that the left eye is mildly toast. Okay, but my resident didn't believe me. Okay, so because the patient was lying in the bed, wasn't convinced. So I had to convince him. So what did I do to convince him? I showed him this. It's called the inverse ptosis sign. Are you all familiar with this? Very useful sign. So basically what you do is you ask the patient, this is the abnormal eye, this is the normal eye. Ask the patient to look up until the 6 o'clock position clears the lid. It's cleared, right? Now at that time you quickly look here. It's covered. So that means not only is the upper eyelid coming down, but the lower eyelid is going up. So this is inverse ptosis, which confirms the ptosis in the first place, but also tells you that this is Horner syndrome. Because only in Horner syndrome you have this both upper lid coming down and lower lid coming up. So very useful sign for people who couldn't appreciate the first ptosis. So next day, of course, in the ward is much clearer. It's always the case, right? The next morning, everything clears up. So much clearer in the ward that he's got reverse ptosis as well as ptosis. So what do? We look at the pupils. And you can see, now this is an important part of the exam, because yesterday we were showing about looking for direct reflex and indirect reflex, where you use a torch and shine into the eye. But for us Asian patients and African patients, our iris is very dark, so we can't see the pupil size. We need to illuminate the pupil. But you only need enough light to illuminate the pupil, not to constrict the pupil. Because in Horner syndrome, the constriction is the same. So many of many physicians, including myself, in the ward setting, we miss Horner syndrome because the pupils will constrict equally to light, and we are always focusing on constriction in light. But in the West, this is not a problem because the patient's eyes are very light colored. You can see, without using a torch, you can see one pupil is smaller than the other. But for Asian and African patients, you need to use the light tangentially, like this. Tangentially, I think, tangentially means you don't shine directly, you shine slightly off, and just enough to see that this is bigger, this is smaller. But if you shine straight in, both will constrict to the same size. So be careful. So we confirm that this patient has got small pupil. So left meiosis, left ptosis, left inside ptosis, and left Horner syndrome. Now, Horner syndrome, from a neurology point of view, we slightly different approach. We don't do so much pharmacological testing. We have a very simple approach, and I often do this. If you think about Horner syndrome, there are only 4 locations that are important because the sympathetic fibers start from the hypothalamus, but hypothalamus is quiet, clinically quiet. It doesn't manifest with disease. It travels down the pons. Occasionally, ICA syndrome can do this, but in the lateral medulla, very important. It's called pica syndrome or lateral medullary syndrome, where there is Horner syndrome, is a stroke syndrome. Okay, so that's very important cause of Horner syndrome, number one. After lateral medulla, it travels down the spine, and again, the spinal cord, it becomes quiet again until it comes to T1. At T1, it becomes prone to disease. In English, we use the word eloquent, clinically eloquent. That means it becomes obvious. Otherwise, it's very silent. A T1 disease, a T1 spine, it can become prone to disease. And then sympathetic fibers are a bit silly, because they start from the hypothalamus. They should have gone straight to the eye. Instead, they came down to the spinal cord, and then they came out and realized, oh my God, I have to go back to the eye again. So what does it do? He comes out, looks out of the spinal cord, and he sees carotid artery is going up. Very good idea, right? If you hang on to the carotid artery, you can reach the eye. But carotid artery is so far away. So what does he do? He jumps onto the lung apex, and then from the lung apex, second jump, hangs onto the carotid artery, literally on the outside, and then that takes him to the eye. So remember, after T1 spine, apex of the lung, tumor can cause Horner syndrome, and any disease that affects the outside, not atherosclerotic disease that affects the outside, trauma, radiation, surgery, dissection of the carotid artery. So essentially, these are the four things. So if you look at these four things, there are other rarer causes, but majority of the time, these are the four important causes of Horner syndrome. So let's work this out. This man has got left Horner's, right? What else is wrong with him? He's got gaze-evoked nystagmus. Straight away, we know it's a central nystagmus, right? Gaze-evoked nystagmus. Look to the left, beats to the left. Looks to the right, beats to the right. So it's gaze-evoked nystagmus. So nystagmus plus Horner syndrome cannot be T1 spine, cannot be lung apex, cannot be carotid artery, must be lateral medullary syndrome. But we don't want to just stop there. We go on and examine him. His cornea reflex, can you see? On the right side, he blinks very well. Okay, on the left side, reduced. Okay, so fifth nerve, Horner syndrome, swallowing and speech problems, ipsilateral cerebellar signs, okay, in the arm and in the leg. And this part, if we can listen to his words, very interesting. Doctor, very strange. When you test my sensation, I can't feel my left side very well, but when you put something cold, my right side cannot feel the cold well. So that tells you that there is loss of temperature sensation on the normal side and loss of position sense on the abnormal side, right? So what did we do? My resident and I took out a diagram, drew circles like this to tell us where are the lesions. 9 and 10 is affected, Horner's is affected, 5th is affected, spinothalamic from the other side is affected. Okay, so we drew a diagram like that, and then we sent it to the radiologist. Please show us a lesion. And she called us and said, yes, there is a lesion in the lateral medulla. So this patient has lateral medullary syndrome. Now again, lateral medullary syndrome is often mistaken in the acute vestibular syndrome as a vestibular neuronitis because they come in with severe vertigo and vomiting. I mean, their eyes are closed, so you don't see the Horner's. And they are not talking to you because they're vomiting all the time, so you don't notice the weakness and numbness. Okay? And then the drift is normal because lateral medulla doesn't involve the pyramidal fibers. Okay? So, and the radiologists will miss this small dot because it looks like an artifact in the terminal part of the MRI. So be very careful. Okay? By using our 4 rules of vertigo, it would have failed because firstly, vertigo, nystagmus is the central nystagmus, associated neurological signs, right? So straight away, even if the scan is normal and head thrust is normal, so this patient would be, even if the scan is normal, you would admit the patient as a stroke, right? But and lateral medullary syndrome, often the scan is labeled as normal because they often see this very small dot at the terminal end of the brain and they will say it's artifact. It's not the radiologist's fault, no, because they're not seeing the patient. They're dependent on what we write in the notes, right? So be careful. Now, I want to teach you one more sign for especially the neurologists in the audience. Okay, this is a useful sign because again, it's a tricky diagnosis in the ED, right? This is a very nice sign. You must look at it. What happens when he closes his eyes? He's going to close his eyes soon. Okay, what happened? Okay, let me give you another example. This is a patient with right lateromedullary syndrome. Right lateromedullary syndrome. See what happens when he closes the eyes. The eyes falling to the ipsilateral side. This is known as lateropulsion. Beautiful sign, super specific for lateromedulla. So you can be very sure in the emergency department you're dealing with lateromedulla. So they keep falling on that same side. If they have lateromedulla on this side, they keep falling. The eyes will say, if your legs can fall, my eyes want to fall. So the eyes also want to fall, right? So when you close the eyes will troop to the abnormal side. When he opens his eyes, the eyes say, oh, wrong side, come back. So this lateropulsion is a beautiful sign, not because you have to do a special maneuver to find it. Okay? So not very obvious in this man, but very obvious in this guy. Close the eyes, falls to the right side, come back. Falls to the right side, come back. Okay? So this is a right lateromedullary syndrome. This man had it, but it's a left lateromedullary syndrome, but very subtle, and I didn't really record it long enough to show it. You saw that? Yeah. Of course, there's an nystagmus also. So this is a paper that if you want to look up, it's a nice review, recent review. I cannot see. Okay. Anyway, I will send to your organizers some of the notes so you can look at it. Okay. So that's Horner syndrome. Okay. So one diagnosis for Horner syndrome is lateromedullary syndrome. What about this woman? She's got left Horner syndrome, clearly. But then she's got no signs of lateromedullary syndrome. But when you go to the limbs, she's paralyzed in the left arm. The left leg is normal. So what happened? She's a motorcyclist, like many in Vietnamese. The motorcycle suddenly stopped. Her arm was still attached to it. She flew, so her brachial plexus was torn. So the T1 part of the brachial plexus was pulled out of the spinal cord. So she has T1 disease. T1 of the brachial plexus. So this is a brachial plexus injury so left arm is completely paralyzed with involvement of T1 part of the spine. So she's got Horner syndrome because of that. Again, very obvious on clinical exam. This lady also very interesting. She came to me not because she had Horner syndrome, but because she had weakness and numbness of the hand. Okay? But a weakness and numbness of the hand fit into a T1 distribution. So that made us look at her eyes, and we noticed that right side is toast and there was right meiosis. So she has got Horner's on the right side. Right Horner's plus wasted hand. So we have to look for T1 spine or just as the nerve comes out. So in her case, it was actually a tumor, and you can see it in the Indian lady gold chain sign. You notice the gold chain comes straight down on this side. This one is going up and coming down because there is a mass. Poor thing, she has a mass there. But she didn't know about it. She came to us for wasted hand. Okay, so we quickly got a scan for her and sent her to the eye doctors. This is a very interesting case that you may be interested in. So this patient came to us in an eye hospital because he's a 32-year-old man who had left hemispheric stroke. Young man with a stroke. So they did the complete workup for young stroke. Then the second doctor wasn't happy, repeated the workup again. Still negative, no AF, nothing, they did all kind of tests. Then as he was in rehab, the rehab doctors noticed that he couldn't see very well with the left eye. Okay, because he was aphasic, they couldn't be sure earlier on. But rehab doctors sometimes are more conscientious than the stroke doctors. So they examined the patient and found left eye not working well. So they sent to the eye clinic. General ophthalmologist saw RAPD. So what does RAPD mean? Optic nerve or brain? Relative afferent pupillary defect with pale disc. So it must be brain. No, nerve. right? Because whenever there is optic nerve, there is a relative afferent pupillary defect with drop in visual acuity. It cannot be a brain problem, or it can be, but most of the time it's not a brain problem or a refractory problem, right? So they looked in the fundus and found central retinal artery occlusion. Central artery. So that is a neurological problem. So you send to our neuro-ophthalmology clinic. In the neuro-ophthalmology clinic, if you listen carefully, firstly, you notice there's a slight ptosis of the left eye. Then in the video, I'm shouting to the nurse, not shouting, but, trying to say, because, in the general clinic, especially in underserved places, very crowded, right, the hospital. So no way you can turn off the lights because it's a common room. So we are trying to dim the room to see whether the pupil is small. Eventually, we convinced ourselves the pupil was smaller on the left eye. So left Horner syndrome, left CRAO, left hemispheric syndrome. What's the diagnosis? Okay, so we talked to the wife. The mystery is the mystery, right? History is in the mystery, or mystery is in the history. The wife told us that he's a woodcutter, from a part of South India, Kerala. And he was carrying large amounts of wood on his shoulder like that. And he was coming home, carrying the wood. And then as he dropped the wood on the floor, his right eye. So what happened, he must have dissected his carotid artery. So the carotid artery dissection narrows the lumen, causes a hemispheric stroke, embolizes to the central retinal artery, causes a CRAO, must have been there since the first day of stroke. But the dissection is on the outside of the wall, so causes Horner syndrome. So good news in a way, right? Because you don't have to do a young stroke workup for him. This is traumatic stroke, right? So we can reassure them that rehabilitation is good. He's not going to get another stroke again. No need to work up for, again, clinical medicine is very useful in this. So likewise, this is a young man with the left Horner syndrome and a stroke. So in a very young patient, 19-year-old, 18-year-old coming to you with a hemispheric stroke, actually more than atrial fibrillation, dissection is the most important cause. And you can help the patient by checking the pupils carefully on the first day in a way to pick up because the nurses and the emergency doctors are looking for pupillary constriction all the time because they are worried about mass effect. So they often miss the Horner syndrome. So you have to look hard like this and then find it, then it will be helpful. Okay, if I can just finish off very quickly with bilateral ptosis. Bilateral ptosis can be muscle, more likely to be muscle. So this patient is muscle because we just called his family in, and this is a Vietnamese family actually. This is some time ago in Ho Chi Minh City. So the mother, the elder sister, younger sister. So this is obviously a familial bilateral ptosis with ophthalmoparesis with minimal zero diplopia. There's only one diagnosis for it, some form of young onset disease. Because myasthenic patients always complain of diplopia. If you have no diplopia, means you must have been having it for so long that you cannot see the double vision. So this is, in this case, we confirmed it to be a CPEO, a mitochondrial disease. Okay. In other disorders, it may be some form of congenital myopathy or congenital myasthenic syndrome. Be careful, okay? So, but it's an early onset disease. So after that, of course, myasthenia. Oh yeah, of course. Other muscle diseases that present with bilateral ptosis, don't forget this one. His zebra stripe is not on the shirt. He's actually on the hands. Okay? He's got bilateral ptosis that's not fatigable. It's an important cause of bilateral ptosis and mild ophthalmoparesis. Okay? And facial weakness also. Some of you may have gotten the diagnosis, but in his hands, the clue will come in a minute. He can contract well, but he cannot relax his hands. So this is myotonic dystrophy. Very good. So this is an important cause of bilateral ptosis and mild ophthalmoparesis. Again, since it's present since birth, the patients are often asymptomatic, except for the weakness. So you can demonstrate the grip myotonia. Okay, that's grip myotonia or percussion myotonia. Sometimes it's very subtle. All these patients have myotonic dystrophy, but you see the features are very subtle. Unless you do the test carefully, you will miss the diagnosis. You must have a checklist. Muscle disease, CPEO, myotonic dystrophy, congenital myopathy, myasthenic, congenital myasthenia. You must have a checklist so that you're right all the time. You can't expect to make the diagnosis just by facial appearance, because this man's face is typical for myotonic dystrophy. Would you, if you see this lady in the streets, would you call her myotonic dystrophy? No, she is myotonic dystrophy. This man also has got myotonic dystrophy. He looks very normal, but they all have clinical myotonia. So you have to actively look for it. And even though I do muscle disorders, I miss this kind of patients many times, because again, same mistake. Rely on spot diagnosis without going through a checklist. Okay? Percussion myotonia, you percuss, pop, goes up. Okay? Pop, goes up. Okay? You have to actively do it. Huh? So that's for muscle disorders, CPO, myotonic dystrophy, and some form of in early onset muscle disease, including congenital myasthenia. Okay? So this is another case of early onset muscle disease. What is the clue? I think Dr. Nishino talked about it yesterday. The clue is a long, thin face, but the high arch palate. What is a high arch palate? If you have to, if I look at this lady's palate, I can ask her to open her mouth and I can see it, right? But if you have to squat down on the floor and then look, and then finally you see the roof, that is a high arch palate. So you notice in this case, I will be sitting on the floor and taking a picture from below. Then only I can see the palate. It's so high arched. Sorry, it's a bit long. Okay. There we are. Can you see? I have to really go all the way down and then shine the torch. And even then, it's difficult to see, and then you can see. It's super thin, super long, and thin. So this means the muscle weakness must have been there. This man also, okay, congenital myasthenic syndrome since young he had it. Okay, of course, we must remember myasthenia as a cause of bilateral ptosis. So this man, again, you can demonstrate the ptosis by looking to the side, do the fatigability testing. Again, you see the lead coming down by asking him to look to the side. Okay? Then if it's a third nerve, you remember if you use the 4 rules of the cranial nerve, you realize that bilateral third can occur in the context of either brainstem or Guillain-Barré syndrome. Okay? So this patient, for example, I think I don't have examples of that. Yeah, this patient is a patient with a brainstem third nerve, meaning it's a nuclear third nerve. Now, I don't want to confuse you. Earlier on, I showed you a patient with a fascicular third nerve. That means as the third nerve comes out and travels through the brainstem, it's a fascicle of the third nerve. But if the nucleus of the third nerve is affected, it's often bilateral ptosis, bilateral pupillary involvement, right? That's a nuclear third. So this man has got a nuclear third, and that's why he's so drowsy. He's quadriplegic. He needs a nasogastric tube. And both pupils are affected, both lids are affected. And then, of course, this is a Miller-Fisher syndrome with bilateral ptosis and bilateral third and fourth nerve and sixth nerve. Okay? So, in summary, unilateral ptosis, bilateral ptosis, the key is the pupils and a system of using muscle, neuromuscular junction, nerve as your template. Okay? I think I'm going to hand over the rest of the session to Dr. She's got a few more topics. Thank you very much for your attention. I will send the notes through Dr. Say. Dr. Say. I'll send it to him and then ask him to distribute to you all. Yes. The slides and the video. Thank you.
Okay, so I'll wrap up with a few cases and we'll finish up the session. Thanks everyone for your attention. I hope you guys were able to pick up some things to learn to use in your practice as you head back and be able to utilize some of the things you learned from here. So the last few cases start with, again, thinking about whether this is in the nerve or the brain, right? This is a 30-year-old man. He reports that he has gray cloud over the right eye. So he has some gray cloudiness. It's not raining cloud, it's just cloudiness in his vision. So 3 days before he came to our clinic, he noticed that when he was lifting weights, he's in the gym, he's somewhat of an athlete type, want to look good. And as he's working out, he noticed his vision symptoms right away. The right eye is blurry, and there's a gray cloud over the right eye. There's some pain that when he moves his eyes around, he notices a little bit of sensitivity. So that's within the 2 days before. And on the day of, he continues to have that blurry vision, that mild headache that occurred. And now he also noticed that there's a bit of numbness and tingling in his feet. And that's been going on for about 2 months. He didn't think of it before, but we started asking him, and he recognized that he had that. So, young man with new symptoms. Ocular history, really unremarkable. He has this esophageal perforation from food stuck in it, not contributory. Medications, none. He doesn't take. He doesn't have any allergies. And he's actually a detective in the local police department. So he stays pretty active and works with some stress. Family history, really, it doesn't contribute in this setting. And otherwise, we asked this review system of other things that might be going on, and he really didn't review anything. So, moving to exam. Right eye is 2200, left eye is 2020. He is not able to see the color vision in the right eye. He misses a few in the left eye, but there is definitely a change in the right eye in terms of color vision. His pupils are reactive, but he does have that relative afferent pupillary defect. And again, we talked about pupils being part of an optic nerve issue. Confrontation fields, full, and the rest of the eye exam, including the extraocular movements, are normal, and that tells you the efferent system is normal. So far, what do you think? Visions decrease, color visions decrease, there's a relative afferent pupillary defect. Where do you localize that to? Optic nerve. I heard that. Great. So you guys learned something from me. Hopefully that's true. But we are missing some information still. What about his visual field? And so when we do his visual field, in his right eye, he doesn't see anything at all. In the left eye, he sees there's a few spots that he's missing. Just a little up here. You can see those. The reason why you're not seeing it is because you're looking at the grayscale up there, and this is the blind spot, which is normal. But we often, when clinically we look at the visual field, we actually look at this, what's called a pattern deviation map. And indeed, he has a few spots in this area. That pattern deviation map takes away the age component and noise that's in the testing that allows us to see a true defect in their visual field. So when I look at that as an ophthalmologist, I'd say there is a slight decrease in that area. So he has a visual field defect in both. One side he couldn't do, the other side he has that area of defect. There's the optic nerves. In the right eye, would you say certainly there's changes consistent in the obscuration? It's not clear, although it's round. There's this change in color in the right side compared to left side. The left side looks pretty decent. And it really doesn't correspond to the visual field that I saw either. So let's review that. Again, is this in the nerve or in the brain? He has abnormal vision in the right side, unable to see color vision, visual field in the right blocked, maybe in the left as well. You say it's optic nerve? You say it's brain? What do you think? I think I heard optic nerve earlier. Are you going to commit to that? Okay, we're going to stick with optic nerve. So we went ahead and did an MRI to see why he has this sudden vision loss. And there's the MRI. So this is an MRI orbit, and you can see fat suppression, and indeed you should see a signal difference between the two, yeah? This is an axial view, and there's the optic nerve. There's the optic nerve. And there's a color difference between the two. Hyperintensity in the right side. And when you look at the coronal view, same thing. It's nicely fat suppressed, but this area is brighter than this area. So indeed, there is something going on with the optic nerve. This patient actually has, let me go back, right optic neuritis. Interestingly, when you have optic neuritis in the United States, our most common first thought is going to be MS related. But for you all, probably not the case. Likely NMO. And you're aware of MOGAD, MOG as well. So those are considerations. But there's certain features about this that looks like what we call MS related or idiopathic optic neuritis. What it is that nerve is nicely enhanced. There's a short segments within the intraorbital area, and it's the perineal tissue is not enhanced. That's consistent with idiopathic optic neuritis. But interestingly, this patient, recall, and as I said, the mystery is also in the history. He had some numbness and tingling in his feet, and so we actually, when we do these images, we actually obtain MRI brain as well. And the reason why we do MRI brain, we actually end up finding lesions in there. And so for this patient, you actually have both brain and the orbit involved. And this gives us an indication of how likely this is MS versus non-MS. That's why we do the MRI brain. So the final diagnosis is idiopathic optic neuritis, likely demyelinating, and this clinically isolated syndrome due to the hyperintensities. So it's in both the nerve and the brain. In optic neuritis, the description is this is a subacute loss in vision lasting 1 to 2 weeks, or starting 1 to 2 weeks, can be spontaneously recovered over weeks to months, not more than 3 months, and certainly by 6 months you should be thinking about something different. 90% of the time you're going to get pain with eye movement. That's a very good sensitive pickup. And there's decrease in vision from 20/20 to light perception. And I'm keeping this as a generic optic neuritis because I want to delineate the 3 different types that is common. Certainly you can have a relative afferent pupillary defect, a visual field defect that is diffuse, can sometimes be an altitudinal, like half up or half down, or enlarged blind spot. Sometimes that happens. They can develop what's called a Polfrix phenomenon. Have you ever heard of Polfrix before? So in Polfrix phenomenon, when one eye is really blurry, when things move in front of them in a straight line, these patients actually don't see a straight line. They see a curved line. And that's actually dangerous if you're driving, for one. Or if you're playing ball, like baseball, and the ball gets thrown at you, instead of seeing it going straight, it becomes curved instead. And so that's Polfrix phenomenon. And then there's Uthoff's phenomenon. Are you familiar with Uthoff's phenomenon? Some of them nod and okay. So Uthoff's phenomenon is named after Dr. Uthoff, who noticed that patients who have optic neuritis and has healed after some time, when they take a hot bath or a hot shower, they elicit the same symptoms as when they develop that optic neuritis. And so it's a reoccurrence of the symptoms when it's heated. Most patients who have MS or optic neuritis, they need to be cool. The cooler the temperatures are, the symptoms are lessened. If you increase temperature, the symptoms come back much more rapidly. And that's Uthoff. Now, if it lasts more than 24 hours, it may be a demyelinating process. So you need to reinvestigate that. But Uthoff is usually within hours. You cool down, it gets better. Okay, so that's Uthoff's phenomenon. And one of the things as an ophthalmologist sometimes we'll do is contrast sensitivity. We can pick up decreased vision quickly, meaning that sometimes people will come in and their vision is still 20/20, but they tell you, I still don't see well, even though it's 20/20. And that's because it decreases the quality of the glare vision. So when there are lights that come, you notice at dusk and dawn, glare hits you, even though you can see just fine. It's that discomfort with the glare. So these patients will notice that more in one eye compared to the other. That's called abnormal contrast sensitivity. So the three types of optic neuritis to be familiar with and kind of within your mind when you think about optic neuritis. One is that idiopathic related to MS. Number two, NMOSD, certainly. And then the other one is MOGAN. Now, there are other types of optic neuritis too, infectious and medication-induced and so forth, but the three I want to concentrate on are these three today. And how are they different? They're different in terms of visual acuity loss. In idiopathic, the vision can be about either 2200 or better. They don't tend to be worse than 2200. They can or may not have optic nerve swelling. So they may have a relative afferent pupillary defect, they may have color vision loss, but the nerve looks okay in a lot of cases. And what's also telling is how it looks on MRI. In MRI, we get a short segment of enhancement that we will find. So it's not as long as the other ones. Well, in order for you to see what's long, you need to see what the other ones look like. In NMOSD, it's common to occur in both eyes, and it commonly occurs near the chiasm, so away from the eye itself, therefore less likely to be swollen. So the nerve tends to be nice and flat. You can't tell that there's something going on. And sometimes they don't feel pain either. So that 90% of people who have optic neuritis that has pain with eye movement, those with NMO don't. And you don't want to dismiss optic neuritis for that reason. And because it's in the chiasm, it's affecting both nerves. Sometimes you don't get a relative afferent pupillary defect. You may get decreased vision, and that visual acuity is actually quite significant, 2200 or worse, usually. And so those are the clues at which you may think that this is optic neuritis and it's NMO. And that MRI, you'll see long segment of enhancement involving the chiasm. And as I said, the chiasm is where the nerves come together, right? And then they split apart that way. So that's where those fibers cross. And that's where the NMO spectrum disorder often affects in terms of optic neuritis. In MOG-associated disease, so I pronounce it as MOGAD for short. That's what our colleagues call it now, MOGAD. In those patients, the swelling of the optic nerve is really prominent because the inflammation actually occurs in the proximal nerve, and it actually can affect both eyes. So you get prominent swelling of the optic nerve, long segment of enhancement, but the tissue that is around the fatty tissue and so forth also gets enhanced as well. For some reason, MOGAD inflamed the tissue around the nerve. And so when you see the optic nerve also enhanced, and you see the tissue around the optic nerve in the orbit, in this area here and here, we call that perineal tissue enhancement. That is very consistent with MOGAD. Now, other things can do that too, such as sarcoid and sometimes TB. But for the most part, in terms of demyelination, those three are MOGAD versus NMOSD versus MS. So those are the three most common. All right. When we do MRIs for idiopathic optic neuritis, what we're trying to do is to stratify and to determine if these patients need to be under immunomodulating therapy, whether they need to be on MS medication or not. In some cases, patients may have idiopathic optic neuritis and have once occurred and no big deal, and it doesn't happen again. But if you find lesions that also occur in the brain, that increases the risk of MS. And certainly our neuroimmunologists are more likely to start them on medications rather than not. The reason is because in a lot of patients with optic neuritis that's idiopathic, we know that for most of them, when they recover, their vision comes back. So you don't have to give them steroids. But in NMOSD and in MOGAD, you definitely need to. Those are scenarios in which time is vision. If you wait too long, you lose more vision. and they do respond to steroids. At least the MOGAD does. NMOSD, you want to probably start on immunotherapy sooner rather than later. And I'm sure you're much more familiar with that. Okay. So that is optic neuritis. And then I'll go through one more and we're done. Any other questions? Are you guys taking this really well? Does it seem like it will help with your practice? Yeah? Good. All right. So here's the last one. Is this brain or optic nerve again? Oh, let me share it. This is a 72-year-old man with blurry vision in the right eye. This occurred about 2 to 3 weeks before. He says, his glasses are dirty. This is what I feel. And there's shadows all around. I feel like if I just can clean my glasses, my eyes, I can see better. It just happened suddenly. He woke up noticing it in the morning. Never happened before. He has no headache. He has no scalp tenderness. He has no jaw pain. And there's no weight loss and no fever. And why did I mention all that? There's a condition that is treatable very quickly, and that's called giant cell arteritis. And those are the history that you want to obtain to make sure that they don't have those symptoms. And if they do, hopefully you know to give them steroids right away. All right. So when he came in, his vision is 2100 in the right eye and normal in the left eye. He has a relative afferent pupillary defect in the right side, and he has no color vision in the right eye. So all three of those are affected. So can you tell me where that can localize to now? The nerve. Great. It's a possibility. So with the vision loss as significant as that, certainly you want to think about that. But we're still missing some information, so I'm going to give you some more information. So this is the optic nerves. Both optic nerves are swollen. And then his visual field. You may see that his visual field has a very atypical pattern. It's not necessarily respecting the vertical, right? And it's not really respecting the horizontal. Or maybe if you argue, with yourself, you might say, well, maybe a little, but it's not consistent. It's not a strong contribution here. And so what are you going to do if this patient is in your chair, in your room with you? And they said that they lost significant vision and this is what has happened. Do you image or not? You think you would image? Yeah. I would too. The reason is because if the vision was preserved, meaning that if they were seeing 20/20 in this visual field, I might be less inclined. I might say, well, we'll look into this. Maybe we'll do it later. But in this case, the vision was 2100. It's significant enough and it impairs quality of life. So we did a workup. And the only thing we found was that there's this narrowing of his left transverse sinus, but the rest of his workup was really unremarkable. And his MRI orbit did not show any evidence of enhancement or changes in the optic nerve. So we did not find anything contributory in the serum workup or the neuroimaging. All right, so what is it? We proceeded further because, again, this vision loss was severe enough. We wanted to make sure we gave an answer. We actually did a lumbar puncture on him as well. And the lumbar puncture did not show increased intracranial pressure. And the proteins and cells and all that was normal as well. Now, his glucose is mildly high. I'm not excited about that. It's not contributory either. So he comes back 10 days later for follow-up, and his optic nerves now look like this. The swelling looks like it's gotten better. Would you agree? And it's painless. He doesn't think it's gotten worse, but his vision did not come back. So what do you think this is? Thoughts? It's certainly different from all the ones that you've seen. This patient actually has non-arteritic ischemic optic neuropathy. Have you heard of that? So it's not arteritic. We talked about arteritis inflammatory issues already, and his inflammatory markers were not elevated. In these patients, and he actually ended up having a temporal artery biopsy also, and that was negative. So bilateral, simultaneous, non-arteritic ischemic optic neuropathy is what this patient has. It's not uncommon in patients who are in the older, over 50s, typically in their 60s, if they have risk factors. And those risk factors include if they have high blood pressure for a long period of time, where their blood pressure fluctuates a lot. If they have sleep apnea, if they have diabetes, is not necessarily, depending on who you talk to, whether it's correlated, but changes in blood supply to the nerve, whether it drops too much, is the big concern. Patients who take certain medications like Viagra can add to that too, because it changes the blood supply. And then if they smoke, that also increases the risk to this also. And in these patients, truly, if they had come in with preserved central vision and no pain, I normally don't even do an MRI because the findings are very consistent with it. But because he had it happen in both eyes at once and his vision was decreased, this is why we did all the workup for him. And fortunately, everything else was okay. So that's an example of sometimes eye-only issue and not brain. So this was in both optic nerves instead of the brain. All right, almost done. I have now a 78-year-old man who tells me, I got up to go to the bathroom and I couldn't see in the right eye. Before that, I was fine. So he was actually in the hospital. So they actually called the people on call to come and see him. He's being admitted for something else, but he developed it suddenly as he got up to go to the bathroom. The ophthalmologist saw the patient in the hospital and said, oh, no, I need to have the neurologist here. This is not just an eye problem. So they called the neurologist. So I'm going to give you a little bit background to the history here. 3 weeks before this, he developed some mild headaches over the right brow. They were relieved with some ibuprofen. 2 weeks before that, before coming in, he was bedridden because of a slip disc. That's why he was admitted, because of back problems, likely needing surgery. And on the day of when this happened, he said his vision was normal. He went to sleep. He woke up, went to the bathroom. There was no pain, but he couldn't see through the right eye. He still has that mild brow ache. It did relieve with some ibuprofen. There's no fevers, no scalp tenderness, no jaw claudication. He did lose some weight, but the back pain made him lose his appetite. He couldn't eat much, and he had some hip pain when he stands. Other history of cataract surgery, not related. Medications, aspirin is what he takes, some vitamin supplements, and pain medication. Social history, he quit smoking in 1973, so for a while now, he's considered a non-smoker, and he drinks about 2 to 2.5 glasses of alcohol a day. Family history was not helpful at this point. And here's his vision. He had light perception with projection in the right eye and 20/30 in the left eye. He could not do color vision in the right eye, normal in the left eye. He has a dense relative afferent pupillary defect, meaning it's so easy to see that relative afferent pupillary defect. And his extraocular motility is normal, so his efferent system is normal. The rest of the neurologic exam, other than the difficulty in walking, was normal. Okay, so reflexes, strength, everything was normal. So what do you think is going on now? Is this a nerve problem, optic nerve problem, or brain problem? Well, let's review it then. Visual acuity, definitely decrease in the right eye. He has a dense relative afferent pupillary defect. No color vision. So, doesn't that localize to the nerve? Yes? Okay, I see nods. That's what his nerves look like. So the right optic nerve looks kind of pale. Yeah. And you may see something in the retina as well. I know you don't look at retinas very often. And the left eye looks okay. And why did the ophthalmologist say that the neurologist needs to see this patient? Because it seems like it's all in the eye right now. Mm-hmm. So temporal arteritis is definitely a possibility. You're right. But remember that all the symptoms he didn't have, just pain. Can that be possible? Right? Yes, you're right. It's still possible. It's less likely on our differential, but someone with a loss of vision suddenly, painless, you still have to consider that, especially when it's significant. It's light perception. That's really bad. If it's non-arteritic, it tends to preserve the central vision. So they tend to have 20/20/20 or better. All right. So the reason why they called neurology for this patient was because with something you mentioned earlier, the possibility of painless vision loss that's significant may have to do with a vascular issue. This patient actually has a central retinal artery occlusion. And that central retinal artery occlusion currently in the United States, we consider that a stroke, and we activate a stroke code and determine we actually give them alteplase. So we actually give them IV alteplase if it's within the 4-hour window as well. So as you recall, the ophthalmic artery is as the first branch of the internal carotid artery, and it goes to the optic nerve, and there it supplies with the central artery, retinal artery. And so if you have something that is in that internal carotid artery proximally to the heart, certainly can break up and go into the eye. One of which is what Dr. Uma talked about earlier with a carotid dissection, for instance, that can do that. Or a thrombus, something in the heart itself can do that. If they have atrial fibrillation, they can induce that as well. So this patient, this is a good description of how the eye is related to the circle of Willis itself, and how we're all connected from the heart and the body onto the eye. The eye is not a separate entity. Anything that affects the body can affect the eye as well. And in a CRAO like this, the ischemia due to the occlusion of the central retinal artery, again, can look very normal in the hyperacute phase, but later on, you start to see whitening of the retina and the cherry red spot in the middle. And I realize you don't see that very often, but if you get that description, that should be what you should be thinking about. This patient actually did develop a carotid artery dissection. And in that carotid artery dissection, you can see that the lumen then becomes compressed because you now create a false lumen to the side. And that pushes on, and then it compresses the ability of the blood to flow into the ophthalmic artery. And that's how he developed the central retinal artery. And that's the workup we did for him. And that's how we found his carotid artery dissection. Okay, I'm going to skip on to the very last. All right. So in an examination, a relative afferent pupillary defect with fundus exam that has pallid discs and edema, often what we think about in those patients is giant cell arteritis. In a CRAO, we don't dismiss giant cell arteritis. In patients who have a branch artery occlusion, so in the retina, when the central artery comes out, it branches, that becomes a branch retinal artery. And that can also be occluded. That typically is not giant cell arteritis, but is not dismissive. You can still have giant cell arteritis in that case. So if the clinical suspicion is high in someone who is above 54 years old with jaw claudication, as you mentioned, loss of vision that's sudden, that's very severe, or worse than 2200, it is very, I think it's very appropriate for you to start them on steroids and do a workup, even though even when it turns out to be negative, you're not at fault for that, because in those patients, you're trying to protect that contralateral eye to make sure that they don't lose further vision, because they can go blind quickly. Laboratory workup for giant cell arteritis is going to be ESR, CRP, and the sensitivity is higher if you combine the two. ESR is more of a non-specific finding, so any inflammatory condition can increase that as well. But combined with CRP and platelets, that gives you a higher pretest probability that that might be giant cell arteritis. And then, of course, making sure that other labs for other causes is looked into if you have suspicion. All right? And always start off treating them. And that is it. You have 7 minutes. It was a pleasure. I look forward to meeting you all again. I hope that I've conveyed some information that's useful for you. I try to get information that's relevant to your practice. I know my practice might be a little different, but please don't hesitate to reach out and ask any questions in the future. I am leaving my contact information with the people who organized, and they can reach out to me as well. Okay.